Hello, everyone. I'm Michael McNutt, Vice President of Education and Marketing with Weedy, and welcome to a Weedy Virtual Spotlight CMS 0057 implementation, Access APIs. It's my pleasure to introduce Charles Stellar, Weedy's President and CEO.
Thank you, Michael. And as I was mentioning earlier, we have still about 400 people to join us that have pre-registered, a total of almost 600 people. So people will be joining us, I assume, as we see that participant numbers go up. In any event, it is a pleasure for me to open up our event today, our spotlight. Um, I'm Charles Stellar, President and CEO at Weedy. I've been here since early 2016. So it has been a pleasure of mine to work with the many, not only the leaders of Weedy, whether it's the board, whether it's work groups, whether it's committees, um, whether it's the people that we affiliate with within CMS, ONC, OCR, and other national leaders, um, working with payers, providers, vendors, um, and other as a multi-stakeholder organization. The SDOs, both state and federal government, patient advocacy organizations, and others. So today, on behalf of all of the Weedy colleagues, um, as I said, the board, the members, the work groups, the leaders, I welcome you to, as Michael said, the 0057, speaking in code, it sounds like. Um, so, and Don's going to help us decode this. What does that all mean? So, I want to the agenda. Um, as I talk about Weedy, Weedy was formed in 1991 by the then Secretary of Health and Human Services, Dr. Louis Sullivan. In the 1996, Weedy was named in the HIPAA legislation as an advisor to the Secretary of HHS. We have 18 HIT-focused work groups, sub-work groups, task groups within Weedy. We hope that many of you on the call today are participants within these work groups. That's where the work gets done. And if you're not part of a work group, consider joining one. If you're not part of Weedy, consider joining Weedy. We, we're very fortunate to have the, I guess, 450, 500 volunteers that are part of the fabric of Weedy, and we thank you if you're part of that, the participants here today. Our role today is to convene, to facilitate discussion, to educate and influence, and that is exactly what Weedy is all about. You'll see on, as I was talking about the work groups, you'll see the illustration on the screen of the 18 work groups. And this is evolving as we start thinking about other um, uh, interoperability opportunities to share information, to cut down on administrative challenges, to make things work easier. Um, with that, next slide, the agenda today, we're going to, I'll be turning it over to Don in just a few minutes, but we'll have the open access API overview. And I'll introduce Don in just a second. Then, of course, we'll go to the payer-to-payer API, provider access API, the patient access API panel, and then the role of intermediaries. Today we have about 31 speakers. Obviously, some of the speakers have been doubling up on the various panels. But these are people that are authorities. I call authorities in the area. They're people that know the issues, and we're just honored to have them as part of our agenda today. Your voice is needed as we are talking today about the 0057. One of the things that we have in the out in the marketplace is a survey that asks questions about key issues on payer-to-payer, payer access, etc. So that went out, and Michael just added that link to the chat. So hopefully, if you haven't taken the survey, please consider doing that. It's an important part of how we develop our responses and white papers, our comment letters, etc. So this is a survey that we urge you to take. Next slide is one of my favorite slides because I get to introduce Don Rucker. First to thank OneUp Health for their support today that allowed us to make this a complimentary event. OneUp Health, and Don can go into more details, but just the overview is they entered the space in 2017 to tackle the most pressing challenges and that is healthcare data. Their mission is to move the industry to a standards-based, cloud-native, API-enabled infrastructure that supports interoperability across the ecosystem, enables analytics. Today we're pleased to have OneUp's Chief Strategy Officer, Dr. Don Rucker, with us today. You'll hear from Dr. Rucker as he shares an overview of the Access API. I do want to also emphasize Dr. Rucker has been a steady leader, someone that, as you might recall, was heading up ONC before he went to OneUp. At ONC, Dr. Rucker was someone that you could really have discussions and debates, and someone who was open to um, debating issues with you. And I really appreciate that, Don. I know I learned more from you than you learned from me, but nonetheless, I appreciated that time. And again, I thank you today. And we'll turn it over to you.
Uh, Thanks, Charles, and thanks for your incredible leadership over the last number of years here. So let me get into, are folks seeing a slideshow here?
Perfect.
Great. Yeah, Charles, also, congratulations. A well-deserved retirement after, super tricky and complicated navigation of all of the abstract things that you've made, concrete and implemented at Weedy over the years. So, we owe you a debt of thanks there for absolute sure on behalf of the country, if I may be so bold. So today we're talking about the Access APIs, or you're on the wrong webinar. As folks may have gathered, in the turmoil of a new administration, there was a executive order put out that the new administration wanted to sort of take a little bit of time to get their ducks in order on what they're going to say. So there was a request, I guess, an order that some of the communications be halted till they can be put in sort of the newer context. Honestly, I think most of this, if I can give a little inside the Beltway, was really about some of the, shall we say, ongoing issues that go back now many, many years with some of the other HHS agencies and not CMS. So I've taken the huge liberty of, you can pretend I'm Alex Muggy, a pallid imitation for sure, but I've taken and just stolen two of her slides that are actually in the public domain. So I haven't actually stolen anything. Just to set, and she's presented these slides, she and Lorraine Du and other folks have presented these slides multiple times. They're direct from their Access Roll slide deck, but wanted to have everybody up to speed. And so there are two slides here. One are the API interoperability standards. And as you see in the rule, there's patient access. There's, so from the payer, so payer patient access. There's provider access. So from the payer, right? CMS regulates payers. There's provider directory, which we're not really going to talk about today. There's payer to payer. And then there's the prior auth on the payer side, which again is the rich topic of, I think, multiple further WEDI seminars in this thing. What you see on this slide, it's too much to read, but there are a number of standards that are invoked here. And again, this is publicly available. Let's see, the next slide are the recommended IGs that the implementation guide. So these are typically, but not always, HL7 Da Vinci working group guides. The Karen Blue Button is sort of an independent thing, though the Karen folks work very tightly with HL7 and Da Vinci, so they're not competing standards. And again, this is another eye chart, but what you see is that each of the APIs basically has one or two relevant implementation guides that are driving design and adoption. So what I want to talk about today, some of the, we'll talk a little bit about some of the technical details of the APIs and highlight those. But I think in the spirit and tradition of WEDI, what we really want to talk about in this session, and we'll get into a lot more detail in the sessions coming up to follow in each of the panels. So what I wanted to talk about is really how the sort of the broader picture of how you as a business in healthcare, presumably a payer or a provider or somebody in the middle, how you should potentially consider these APIs and, really talk about some of the things that, I think have been discovered and people have talked about over the last couple of years to be, if you will, smart about the APIs. And that's what we're going to do here. You can read some of the topics and we will go over each of these. And we'll start with something that is a little bit of computer science-y. There might be one or two other touches into computer science here, so apologies, and send me hate mail if I don't explain it. But the FHIR application programming interfaces, they're really, in a computer science sense, a thing of beauty. Now, okay, so that identifies one as a nerd. But But when you think about them, our entire modern digital world is all about APIs. It's not about apps. It's not about software. It's about the APIs that connect them and generate value. Um, I mean, just this morning, it's, you know, looking up things, directories, just phone and address, publicly available information. Um, routing, getting the phone to route you to your appointment, um, looking, at your meetings for the day, checking, how brutally cold it is here in Northern Virginia, of all places. All of that, the value is driven by APIs. So that raises the huge question, geez, we don't have anything like that in healthcare. Um, we don't have functional APIs in healthcare. Now, that's not to say we haven't gotten good at exchanging pieces, and Weedy has been the absolute leader in getting the payment world functional. And HL7 has done a ton with things like labs, and the imaging folks have DICOM. But when you talk about the core provision of care, medical notes, problem lists, the story of the patient, right now we're still in the business of having to infer that from other data, then communicating that. So it's worth thinking about, why don't we have that in healthcare, and how can we get it in healthcare? So what are the enabling APIs in the rest of the world? It's really pretty simple. The modern world, there are other kinds of APIs, long discussion, but the modern world is using an API standard called RESTful and a data standard called JSON. So RESTful stands for representational state transfer, and it is what you see in your browser with the gets and puts at the top of the screen. And what it basically says, and this has been around, well, it's been around for a while, but as a described thing, it was in Roy Fielding's PhD thesis from 2001. And I would submit it's hard to come up with a more influential PhD thesis in computer science in this millennium than that one. But love to hear what people think about that. JavaScript object notation, after many starts and stops on representation of data, and here's a an IG, and basically is a move from XML. And the beauty of JSON is you can truly read it. Now, arguably, you can absolutely read XML in your word processing program, but JSON is just sort of simplicity. And so our question, and CMS's question, and ONC's question is, can we get these modern APIs? And again, by way of comparison, the older APIs that have many problems, set are, SOAP and IHE and, XML and some of those things. Can we get these into healthcare? And so the Access APIs are really ground zero, the starting point, along with the ONC Cures Act requirement for FHIR APIs for EHRs. Those two things are really the starting point for getting healthcare into modern computing. They're not the ending point. We all know these things are very early in their lifetime, but they are the starting point. They free up data in a way that it can actually be used. It's not hidden between ancient protocols. It's not hidden by brokers. It's not hidden by private directories. It's available with modern security, which is really a powerful concept. It's the way the entire rest of the world has comported themselves, not necessarily because they wanted to expose APIs, but from a business point of view, they had to. And Alex, I don't know if she's on the call or not, but Alex and Lorraine and the whole CMS team here have done a marvelous job. And I say that as somebody who is not 100% fan of all government programs. Let's leave it at that. But this is really has been awesome, very pro-public. And I think you can absolutely rest assured this will be highly valued in the upcoming administration as it was in prior administrations. Because ultimately, CMS's problem is the broader economy's problem, which is we are grappling with cost and access in healthcare, and we're going to need modern digital approaches. This is what this part of the session is about. So I know everybody thinks of these as compliance, and obviously the title of the talk is 0057, which has, as Charles pointed out, sort of puts you into the land of federal rules, and there are multiple naming schemes which drive, well, all of us batty, I would say, on some level. But don't think of APIs as compliance. Put yourself in the shoes of Elon Musk or Jeff Bezos, or pick your favorite change the world tech titan. See them as a door to a new world, a new way for running your payer business, a new way for running your provider business. And because they're APIs at their heart, they're a way to communicate. So who do you want to communicate with? What apps, what counterparties? And that's what we're going to talk about. So a subcontext of all of this. Now we're sort of seemingly on the claims side here, right? And in the most basic reading, the Access APIs are about claims data through the explanation of benefit via resource in many cases, but they all invoke clinical data as well. And I think in the next 10 years, payment historically, so the entire X12 claims pipe has been claims. It's been purely financial data, with the only clinical data available being really that CPT code and the ICD codes that are embedded in the claim. I would submit that in the future, everybody's going to have to get way more clinical. Did a little clipping here of some of the more recent Medicare Advantage highlights. And I mean, this stuff goes, I saw yesterday that CMS is appealing a judge's decision in favor of United Healthcare on Medicare Advantage data. And many people here, I think, follow this probably pretty closely as part of their job. But the real concept here is Medicare Advantage is a fixed pot of dollars, and everybody in a Medicare Advantage plan is competing with every other Medicare Advantage plan for stars ratings. And the people who perform, who get the best scores, but more importantly, do the most to get the better score, are going to have to move to clinical data. The winners in star ratings are going to be clinical data users, not just folks who infer it from claims. And this clinical data is over the landscape. So risk adjustment, network design, prior auth, utilization management, care management, quality measurement, stars rating, all benefit from clinical data. So just to give you a flavor of some of the categories of star ratings, outcome measures, process measures, more process measures, patient experience, capturing access, improvement measures. You really don't need a super large amount of imagination to look at each of these, drill down into the measures, and ask yourself, how would working APIs improve my score? Whether you're a payer for whom the score is direct, or you're a provider who actually, is going to be incented by payers to do well here. So let's drill a little into the specifics of the APIs. So the big four, we're not talking about the network stuff here. APIs are this, and we're really only going to talk about the first three in this weedy session. Again, more to follow. So just a couple highlights on the payer-patient API. What's included: clinical data, claims data, the encounter data, and now the non-drug prior authorization data is coming up. Turnaround time on the data is a day. The broader prior auth and the newer updates are going to be enforced January 1, 2027. The payer-patient API is already in play right now. And those reporting, then there are also reporting requirements that are part of this. CMS wants to see how this is being used and see what else can or needs to be done here. The reporting requirements have actually already started. The reporting is actually, you have to start building the reports beginning of next year, but it's based on this year's performance, and you have to report out the reports March 31st, 2026. And again, the prior authorization decision-making on the API is 2027, but the reporting is starting now. So, again, some of this is in place. Pictographs are always a little bit of a problem with webinars, but if you follow a couple of the little pictures here, the payers on the left here send data. The data has to be converted to FHIR, and it's the FHIR data that pops the data into the API. And then third-party apps that the member authorizes is how the patient accesses it. You've seen FlexBuzz giving, reports on how good payers are performing here, either doing this all on their own or using a vendor like OneUp or other vendors. There are a number of them out there. And of course, you have to authorize. So as you think about the tools, one of the things is, what's the member's authorization experience? The authorization is invariably the sticky point in use, let's be real. And then reporting, these are just some reports we provide, but you can sort of imagine what reporting is. The next class, and there's no specific order that payer patient came first, but it's dealer choice on whether you want to talk about payer provider, payer next. But payer provider is in the 0057 rule, is really, so again, from the payer to the provider, has the claims data, prior authorization data, but doesn't have the cost sharing data in there. And that data, as with the patient data, goes back to January 1st, 2016. There's an attribution process. The rule has a lot of language on it, but I can net it out for you. Any form of provider attribution, i.e. who should get this data that makes sense to you, is okay. This one, very specifically, is an opt-out. So members have to opt out of this. Keep that opt-out provision in mind. And again, the workflow here is pretty similar, the pictograph, to the last pictograph I showed you, but in the box of your FHIR platform, in the middle, there's an attribution phase. So you get the data in FHIR, you do your attribution. So what providers is this going to, or who are allowed to access it? And then you have the sharing phase. And the very last, there are multiple ways for the provider to get this. That's a little bit of dealer's choice, because these are heavily networked. These are folks who have network contracts. There's some more provision. This is not a classic open ID authorization. There are some other ways and tools and optionality to get at that data. If we look again, but somehow you have to register, so think about that. Payer to payer, let me start. The eagle eye will have noticed that here I have a bidirectional arrow. So technically, the 0057 rule says the new payer, let's say patient, so classically, from commercial to Medicare Advantage, or often one Medicare Advantage plan to another. The payer to payer has to, the new payer has to get the data essentially instantaneously, here within a week from the prior payer. But obviously, these are going to be bidirectional APIs. And so, the arrow in essence goes both ways. And it's roughly the same payload. Again, subtle differences. Prior authorization doesn't require economics and is only for approved claims. Denied claims do not have to be sent. And the thinking here from CMS was, this is a continuity of care. So you have a new payer. It's January 5th, so that the new payer doesn't run you through the entire prior authorization process on a medication you've been on for years. They have to honor the incumbent payer's prior auth for 90 days. So this is facilitating continuity of care with respect to prior authorization. Think of it that. The other big thing here is it's opt-in. Now, presumably, opt-in here is not the hugest lift in the world, because the patient presumably has just joined your plan. So this should be part of your onboarding process. But again, think about what your onboarding is, because that's part of it. The enforcement dates we've talked about. And again, here, in this pictograph, we sort of have bidirectionality to it. And then, the opt-in, and in the middle, you have to collect opt-ins and previous payer information. If you think about the one I just talked about, the payer to provider, there the opt-out you can be a little bit more flexible on that. Again, a lot of subtle details. We could spend hours on this. And again, an opt-in experience, outbound, the same. So we've looked at these things in the industry as sort of a compliance checkbox. But I'm here to convince you that for true success and business impact in winning, right? Not to quote any new presidents, but healthcare has many opportunities to do so much winning. We're sort of behind the ball, so we have a lot of winning opportunities, and APIs are at the heart of most of them. I would hopefully optimistically suggest. This is the old Ghostbusters. Who are you going to call, right? Think of the API as a communication tool. Don't think of it as, oh, I checked the box, somebody can test against it. Think of this as a communication tool. But beyond communication, right? Communication with your patients, right? On their ongoing healthcare, management of chronic disease, communication with providers, right? Communication with providers does not all need to be the electroshock therapy of prior auth, right? You can actually do stuff in a more modern, automated way. But the deeper win here, ultimately, of APIs is not the API, but what's underneath the API. And that win is the entry point to highly computable information. Now, sadly, because of failures of public payment policy, our current crop of EMRs have near zero computability and near zero automation. Their entire history is to gin up a higher billing code. And that's what we've asked of them as a country. And sure enough, they've done a nice job, arguably, in providing that. Our EMRs, which are our systems of record on the provider side, though, don't in any way look like modern enterprise software, right? If you went to any modern big data company, manufacturing, service, and showed them, compared what they're doing today with what we can compute and automate in our EMRs, it would be a sad day for those of us in healthcare. So our goal here with the APIs is to envelop patient care with rich computation and from all the way from prevention through chronic disease. Think of it as the ultimate CRM, customer relations management software. And I'm guessing, who knows what Senate confirmation hearings hold, but I'm guessing that if Bobby Kennedy, becomes, as looks likely, the Secretary of HHS, we're going to have a different look at prevention, and all of this will be we will be more incented here. Let's leave it at that. And so what do you need here? Well, of course, you need seamless real-time communication. We know what we get on our smartphone. And so you can work backward from what you get on your smartphone to what we should have in our platforms. I like to refer to this as computable interoperability. And when you think about computable interoperability, because this is the heart of modernity in healthcare, it's not just packets of data. It's not just batch mode things going back and forth and then storing them in a clunky enterprise data warehouse with, only to be gotten out by complicated SQL queries and Tableau or Splunk or, business, BI type of things. It's really real-time APIs that are live. I mean, this is what you get when you're traveling on a commercial airliner. This is what you get when you wonder where your package is from FedEx or Amazon. This is what we need in healthcare. And as you look at your expenses and costs, you have huge opportunities to make your analytics and monitoring much better. I think a big issue, obviously, is AI. And we all have a certain skepticism about AI, but I tell you, it is working. I'm pleased to be a advisor to GenHealth.ai, Ricky Sahu's second company after OneUp, and they're showing some early but stunning results. They're able, better than any classic statistical algorithm, to predict patient outcomes, and they're doing prior auth several percentage points more efficiently. But those are just two examples. They're going to be everywhere. And so you need to say, not just my API, but do I have a data platform that seamlessly allows me to use AI tools? Or am I in clunky things where I have a JavaScript persistence layer in front of a SQL database and have all kinds of clunkiness on, let's say your Fire server that will effectively prevent you from doing modern computing? Now, again, in healthcare, I don't think you can really look at currently any real modern data architectures. I'm just going to throw out there, no disrespect, and a lot of people have been quite successful, but Mumps is not a modern data store. And I'm not going to name any names here, but everybody knows. So how do you think about modern interoperability? And in the rest of the world, this has coalesced over 30 years in this migration from relational databases, then to NoSQL databases, to data lakes, then to Lakehouse, which is, if you will, the best of all worlds, powered by lots of metadata. So I'm going to suggest maybe there are other big data patterns out there that you can make successful, but much of the modern Silicon Valley world is going to Lakehouse architectures. And I'm going to suggest that if you're not, you ought to really understand why not. And again, there's a zillion YouTube videos and things written about Lakehouse architecture. So, we'll just leave that out there. So I know TEFCA comes up in a lot of these discussions. We're going to have more of that today. But when you compare some of these things with TEFCA, I think you're going to find that the reason the rest of the world went away from, AOL and Yahoo and the broker's 1990 API style is because RESTful is way more power. You don't need any form of brokerage. These URLs can be made directly available. It's actually part of the Cures Act. And for payer to provider and payer to pay APIs, it's easy to know who your counterparties are, right? They're in network, or it's a limited address space. There's only order 1,000 payers in the United States that are relevant here. Payer to patient, of course, is under patient control. Another thing, as you think about behind these APIs, is modern security. These APIs I've just talked about all are readily done with zero trust. I think one of the challenges for the folks in TEFCA, and we'll hear maybe more today, is they're operating in a world of just trust me. Everybody just kumbaya. And that's not the way the rest of the world works. I think there's also huge questions. These APIs, as described, all have robust authorization chains. So they're not making up outside of federal rulemaking, and in frankly contradistinction to federal rulemaking over the last 40 years. They're not making up permissions and permitted use cases outside of HIPAA that have not been tested because they're not part of the federal rulemaking process. So you're going to want to think about your cryptographic chain of custody here as well. Again, modern APIs provide that in spades. So let me conclude. All of this data movement is a great opportunity for WEDI. WEDI has done so much in moving data. I see WEDI and the HL7 sort of working hand in glove, HL7 and Da Vinci on getting the data, having the data standards, and then WEDI on the operational side. The future of payment is going to come through clinical data. Yes, it is in claims today, but the future is going to be clinical data. The entire world has agreed what the building blocks for modern APIs are. They're JSON, in healthcare, FHIR is the healthcare implementation of JSON. Thank you, Graham Grieve. And RESTful. So if you haven't had a chance, there's lots of videos, lots written about these things. But that's where the world is going. That's everything on your browser. It's everything on your smartphone today. Every one of those icons on your smartphone today, dollars to donuts, is using RESTful to communicate with a server. So it is available. I know, some folks have said RESTful APIs aren't, available. I know, frankly, Sequoia has made that point. I think you have to sort of comport that with, what you see in with your own eyes. The bulk FHIR API, which truth be told is a batch mode API, is really a turbocharger for these business data flows, and can be put into all of them. It's a new political administration, as we all have heard nonstop for the last half year. And, you like me and everybody else is finally, amen. Maybe we can hear about something else now. But you can bet that modern APIs will be part of many solutions. And stay tuned. So with that, want to thank folks. I don't know if they're QAs. I'm unfortunately not a multitasker, so I didn't look at the chat things, but I don't know. Michael, are there questions that you want me to answer? Or I know we're just a little bit over time.
Actually, Dr. Orker, once again, thank you so much for that presentation. We are out of time, unfortunately, but I do welcome you, Kate, and the rest of your one-up team to review the chat if you can at this time to see if there's any open questions. Folks, feel free to ask questions in the chat as we move on to our next panel. Dr. Rucker, how's that sound?
Sounds perfect.
Excellent. Once again, thank you so much for a full and entertaining presentation. We thank you always for the support you give WEDI.
That's my job. Let's go on.
All right. First of our 4 panel presentations, it's my pleasure to introduce Denny Brennan with the Massachusetts Health Data Consortium. He'll be the moderator for the Payer-to-Payer API panel.
Thank you, Michael. Denny Brennan here from the Massachusetts Health Data Consortium, and I'm very pleased and privileged to moderate a panel of some distinguished guests of WEDI and members of WEDI, including Nancy Bevan from Medica, Bob Oakley from Evernorth, John Roskowiak from CenCal Health, Samantha Birch from AHIP, and Karuna Rawani from the Blue Cross Blue Shield Association. I'm going to ask each of you to take a moment to introduce yourself, but we're going to be spending the next 45 minutes talking about the payer-to-payer API that Don Rucker just elucidated for us earlier. So with that, I'm going to look to our panel, and I'm bringing up my speaker mode so I can see everybody who's here. And let's see, why don't we start with Karuna, why don't we start with you? From the Blue Cross Blue Shield Association, could you share with us what your association and what your members' perspectives, activities, and initiatives have been and are focused on with respect to receiving data from new members who have information with other health plans, as well as providing data for your members who are going to other health plans? Can you talk a little bit about your association's position and its work in that area?
Sure. Thanks, Denny. So hi, everybody. My name is Karuna. Thank you for having me. As Denny mentioned, I'm on the Blue Cross Blue Shield Association team. I'm on the interoperability solutions team there. So for those of you that don't know, the association is the parent company for the 33 Blue Cross Blue Shield plans across the nation. So as a system, we are very excited about the direction interoperability is going in. And as one of the founding organizations for Da Vinci, we're very excited to see the implementation guides referenced in regulation. Our plans are very committed to the success of, and they see the value of the interoperability APIs and the CMS 0057 regulation. We're hearing a lot of excitement for the focus on member outcomes and the opportunity to really build trust through transparency. We know that prior auth is a larger lift with the 3 components. Provider access requires a good deal of adoption and change management, whereas payer-to-payer has some traction from the previous regulation that was paused. And there are existing kind of legacy processes that plans already have to acquire historical data for members that they can build upon. So generally, we see a breakdown of the thirds across our plans in terms of their development status. But with the payer-to-payer API, we are seeing that curve compared to the other APIs shifted a little bit more to the right, with more plans further along in their development and testing. And a small number of them are actually operating in the market, although currently with little to no usage. Plans are working on updating their capabilities to meet the most recent expectations for standards and regulation. They're building functionalities like bulk fire and smart app launch. There's new standards such as US Core and Karen that they're integrating. We're seeing an even split across the plans in terms of build, buy versus a combination of both. Plans are actively testing in the testing PDEX and the Connectathons, especially at the most recent one that just happened in January. And then we are hearing about gaps in the industry, like things like the endpoint directory, which I'm sure we'll talk a little bit more about, as well as some plan-specific nuances, such as dealing with sensitive data relative to some specific state laws, standardization of the opt-in policy, things like security and authorization that we heard a little bit about from Don, that I'm sure we'll talk about more today as well. So thank you.
Thank you, Karuna. Samantha, you're nodding in agreement. And so I'm going to go next to you and ask that you share with us what it is that you hear in Karuna's discussion that resonates with you.
Sure. Hi, all. Samantha Birch, Vice President of Technology Public Policy for AHIP. So that's the perspective that I bring, is more of an aggregator of feedback and more from the policy lens. But I think a lot of what Karuna mentioned really resonates in the conversations that we've had on implementation across the AHIP membership. And I think I'll just start by saying, I think that there is some out there that believe that there is more sort of homogeneity in the plan world than there really is. So what might be a major challenge to one plan is not to another. So what I'm really going to do is sort of at a very high level state some of what we've heard, and I'll try to not be too repetitive of what Karuna's already brought up. But there is, from our members' perspective, a great deal of support, continued support for the CMS rules. There's a lot of work that's underway across the APIs, including piloting, and plans see the value in this payer-to-payer exchange. So I think, as with most new technology requirements, it's not unexpected that sometimes regulation can outpace what I'll call the ideal infrastructure for operationalizing. So we've heard in certain circumstances, there might be good opportunity for additional guidance from CMS that would help to address some of these, what I'll call sort of workflow and infrastructure questions about how best to operationalize. So many of the issues that Karuna previously brought up are really what we're hearing about. Sort of scalability, consent management, opt-in, sort of identifying previous payers and so on. And really, how do we balance the goal of automation with this API while recognizing that we want to limit patient burden, and there'll continue to be some processes that will likely require a fair amount of manual effort. So I will also give a shout out, and I'll be a broken record over the next hour and a half or so on the need for a national directory. From a policy perspective and an advocacy perspective, we sort of shout it to anyone who's willing to listen, up into including members of Congress and to the new administration. So while I think we hear that on the P2P side, the endpoints may be more manageable, this issue gets somewhat more acute in the other APIs. So the only other last issue I'll bring up that we hear a fair amount about is the interaction with state policies and how they may diverge from the CMS rules. So our position has been, we need alignment with CMS, and CMS needs to be the North Star that everyone drives to. And I realize that that is highly aspirational, but we'll continue to say that. So I'll stop there, since I know that we'll be diving into more specifics later, but thanks again for having me be part of the conversation.
Well, thank you. And Nancy, Bevan, and Bob Oakley, as health plan representatives, but also co-chairs of Sequoia's payer-to-payer fire implementation work group, you're sitting at the nexus of, plans, technologies, provider directories, some of the things that we've just talked about. Nancy, starting with you, could you introduce yourself and tell us a little bit about what you're seeing in your work with QHINs and your work with Sequoia with respect to facilitating payer-to-payer exchange?
Oh, absolutely. Thanks for having me today. My name is Nancy Bevan, and I'm Director of Interoperability Strategy for Medica Health Plan. I enjoyed listening to Karuna and Samantha because both perspectives have really been front and center for the payer-to-payer work group that Bob and I co-chair for Sequoia, but also as my day job at Medica. Coming from a medium-sized health plan that obviously implemented the payer-to-patient API, we're having to build off the strategy that was initiated for that. But I think medium and small size payers are in probably a much different position from the perspective of resources and maturity of technology. We're seeing that in our work group. We're also seeing that, I see that in the industry and in my own health plan. So I think there's just this question has such a broad perspective. I came from a larger health plan a year ago that had already, put their toe in the water for payer to payer. Probably one of the big payers that Karuna's talking about that is, has some capability, but is not very much operationalized yet, just because nobody's ready. To the perspective of a payer like Medica, who has a lot of work to do to be able to meet this requirement, we just completed a discovery process at Medica where we identified all of our current capabilities and the gaps between our current capabilities and where we need to be by 1/1/27. And I think Samantha touched on a lot of the things that we found of, how are we going to do consent? How are we going to do provider directory? I think from the work group perspective at Sequoia, provider directory becomes front and center with every conversation, because we all say, okay, we can build the APIs. We have the data. Now, how do we connect to each other? And how do we do that? I think the big payers have started learning to connect with each other, but there's hundreds of payers in this country. Nobody said, this rule does not say you only have to connect to the top 5 payers.
Right.
It says you have to connect to whoever the other payer was. So provider directory and the ability to identify where that other payer is just a huge barrier, a huge question in the marketplace right now for how that's going to happen. We're going to talk in a minute too about middle, partners that you can, and where do they play into this space. And Dr. Rucker laid a great groundwork for that conversation. But I think from a medium to small payers perspective, they're going to be critical in our success at doing this. So looking forward to the rest of the discussion today. And hopefully we can help everybody out there with wherever you are in this journey to payer.
Thank you for that. Bob, I'm going to go to you now for Evernorth, and as Nancy's colleague on the Sequoia P2P fire implementation work group. Provide us some of your perspective, especially about some of the issues that Nancy just raised. It's this provider directory is referenced all the time, and everyone's saying, where is it? What is it? How do we use it? Share with us your perspectives on that.
It's a big thanks, Danny. Thank you for having me today. My name is Bob Oakley. I am the strategy and interoperability lead for our physician innovation team within Evernorth, serving our clients and customers across pharmacy benefits, health plans, physicians, and pharmacies. And that Nancy teed up very well, right? That for the big one like Evernorth, we have a sandbox, we have a pair-to-pair API in the sandbox that can be worked through our developer portal. But that is great, right? You check the box from a requirement standpoint. You have the technology in place, but now where do you point that, right? These RESTful APIs require you to know where is the address? How do you access it? And how do you certify that everybody's playing the same with the same interpretation of the regulation, right? So there's some gaps in terms of implementation out there that everyone can meet the letter of the regulation, but then we all stall or have to go through a brutal grinded out connection by connection basis, right? You go into a market, there's 5 health plans operating in the ACA market there, and you got to go connect all 5 of them if you want to exchange data. That's not going to drive adoption. That's not going to enable everyone to gain back their investment, and it'll just be seen as a compliance issue. And I think that would be a loss, because there's tremendous opportunity to serve patients and our members much better with this API. But without that directory, so we're talking about the directory, we're talking about is a list of addresses. Here for if you want to connect with Cigna Health Plan, here is the address for their fire endpoint to connect to, and likewise for every other payer. That has to be maintained as a central repository. And then of course we haven't talked about it, but certification of these APIs is going to be critical as well. So everybody understands that when they send a message to that endpoint, they're going to get back what they expect.
Terrific. Thank you. I appreciate that. John Raskowiak, we're going to turn to you now and ask you from CenCal's perspective, how you envision participating in and using payer-to-payer exchange going forward.
So my background is I've done payer-to-payer, just switched to CenCal. I've done it at my prior plan and we went live. It was a California mandate, but not everybody's participating. So again, for a small plan, here's a perspective. You have very, very limited resources, so you're very vendor dependent. So we had a vendor solution. So with Edifax, they sponsored these sessions in the past. We also then partnered with CAQH for our endpoints for payer-to-payer as well. So the ability for a small plan to connect with all the possible payers a member could have, is just beyond the reach of a small plan. So as the theme has been, is publishing endpoints and being able to connect to all the different plans, and that's the risk, as was brought up earlier, is, gee, what happens if there's a payer that one of my members had in the past, they want us to connect and share the data, but they're not in the payer-to-payer. What's the response? Come back, nothing. But they're going to go through the consent and, process we have in place, consent solution. Sorry, my phone's ringing in the background. There we go. So that is, the problem that needs to be solved, and the difficulty in this for particularly a small plan. So yeah, it's working, it's active, but also too, I can't monitor if the member gets information back. I don't have that directory of who all is exchanging payer-to-payer.
So this challenge, thank you, John, this challenge of finding who to exchange with or from and having a common directory of payers, an endpoint directory as has been specified in the chat, as opposed to a provider directory, which is an entirely different kettle of fish. But as it relates to a payer directory, an endpoint directory for health plans across the country, it's one thing to have that, but it's another thing to be able to use it and to access it. And in today's sessions, we're going to be talking about, among other things, the role of intermediaries. But John, as you've pointed out, Nancy, as you've pointed out, this is not easily accomplished by most organizations on their own. And there are a number of options that are available to organizations out there. Bruna, when you talk to members of the association and talk about the different ways in which you can support your members in receiving and providing health plan data for members, are you looking at a portfolio of exchange approaches? Are you looking at investing or preferring a particular method of exchange? What are you looking at in terms of what intermediary support might be useful for your members as they look at solving this particular challenge?
Definitely a common question from the plans, seeking kind of guidance on the best way to approach this industry issue. I think plans are really focused on making sure their own houses are in order, and we often kind of walk past the graveyard of issues such as patient identifiers and endpoint directories. So what we've been working on to kind of move the needle here is an initiative called the Trebuchet Project. That's how the association has been kind of exploring some of the scaling issues as it relates to Da Vinci. So Trebuchet falls under the Da Vinci umbrella as one of their pilot initiatives. So there's several providers, several plans, several vendors, several intermediaries that are all facilitating connections through eHealth Exchange, which you may be familiar is one of the qualified health information networks through TEFCA. So the whole goal and initiative here is to address issues like endpoint directories and unique payer identifications and be able to actually test out solutions. So some of the work that Sequoia has been doing to actually dive into the requirements and some of the gaps and align on some of the ways forward. This is a testing hub where we can actually put that to use and try out different approaches. We are expecting that some of the work that the National Directory of Health is doing will be able to align some of the endpoint directory approaches across the different resources that are out there. I know CAQH was just mentioned. So we're hoping that some of the work that's being piloted in Oklahoma, I believe, has successful outcomes that can kind of take the next step, whether that's through a regulatory or an industry approach. So that's how we're advising plans currently. And giving them opportunities to sort of test different approaches as the industry marches forward. But we would kind of agree with some of the points made by our friends at AHIP and Sequoia around the need for a national directory strategy overall. And we're advocating for that as well.
Thank you. Samantha, from AHIP's perspective, you have a lot of members and a lot of folks coming to you and saying, we need help. This is a big problem. This is a big challenge. The devil's in the details. Any one of those narratives. Could you share with us some of your perspectives as an association and how you're helping those plans in your association address this, some of these challenges? I can see a plan coming to you and saying, what about security? How do we know the information that we're moving from one plan to another is secured? How do we know that we're as Bob was talking about, that these APIs are certified and that it's going to where it's supposed to go, it's delivering what it's supposed to deliver, and I have confirmation as to that fact and know that it's traceable, auditable, and the like. There's a number of challenges. Can you talk a little bit about what you hear from your members, as Karuna has talked about for the association, what you hear from your members in this regard, and are there any differences with what you hear from Karuna from the Blue Cross Association?
Sure. So I think, again, sort of at an aggregate level, we focus on more of the policy and advocacy side of the implementation of the rules. So we're hearing the challenges, we're creating the forums for members to be able to interact with the regulators. We hold listening sessions with members because really it is, I think, incumbent upon the regulators, and I think CMS has done a great job of partnering with stakeholders to have those conversations on sort of what are the expectations and how do we make this, certainly how do we get to compliance, but how do we make this then more than just compliance, right? Once we fully understand that piece of simply being in compliant with the rule, then I think we've heard it's easier for plans to start to think about all of those great other potential use cases. And then I think, there's sort of the more acute issues, as you've pointed some of them out, but really, again, around those workflows, around opt-in and concurrent payer information. Does the 834 need to be amended? Sort of what are the processes for looking at, again, sort of that data capture and reconciliation? And then, we hear a lot of conversation about what the right customer service model is, right, to get that information complete and correct and actionable from members. So I think we hear about the range, and from a perspective of sitting on the policy side of the shop at AHIP, it really is about articulating those concerns to the regulators or those opportunities, as we pointed out with national directories and some other areas where we've seen an interest from CMS through some piloting to really try to move the ball down the court on some of these issues, and how can we all partner together? Because I think the one thing across all of these APIs is that we all want to solve these infrastructure issues, right? And they very much are more acute for our small to medium-sized members in certain ways. And so how do we solve them across the ecosystem? Because and I come from the hospital side of the world, right? So it's the same scenario where we're not going to get the benefit to patients, right, from all of this data exchange if it's only the well-resourced, most sophisticated organizations that are capable of doing this, because the clarity hasn't been provided by the regulators on the expectations.
Thank you. Nancy, and then Bob, working with Sequoia and working with TEFCA and the QHINs is an interesting model, because TEFCA was created to normalize the provider side of the data system, to make sure that provider EHRs the data was where it was supposed to be, it was in the format it was supposed to be, and however it was exchanged among providers, it was exchangeable. And and providers were able to use a common framework, a common agreement, a common trusted framework. But now comes payer to payer, which is kind of like a tangent to what TEFCA was originally created to do. And yet there are some things that are compelling about the TEFCA proposition for some health plans who are looking to gain the benefits of scale or something else. Could you talk a bit about your thinking in working with Sequoia and working with the payer-to-payer exchange? What led you to Sequoia as opposed to some other kind of intermediary who might be able to support this kind of exchange for you? Maybe there isn't another. But share some of your thinking before you decided to go in this particular direction.
Sure. I'd like to touch on one other thing first, and then I'll get to that.
Certainly,
I
certainly.
do think all this conversation we've had so far about all the different components of being compliant with the payer-to-payer rule, for some of the small and medium-sized payers, and the strategy that we're thinking about taking is owning those things that we have to own, right? We have to have the data. We have to have the data in a position where it can be exposed to the FHIR API. So that's absolutely our responsibility. Consent, we have to be able to address a consent and have a process for that. The training components and the reporting components, those are things that aren't easily given out to other vendors. So I think one of the strategies for this for smaller and medium-sized payers can be gravitate towards those things that you have to own and that you have to do, and make sure you're doing those well. At the same time, be thinking about who are those partners that you could use for some of the other things like connectivity and even FHIR if you're not ready to do that. That's a strategy we're going to take. And then I think as we get that solidified and all of this becomes more operational, you have the opportunity to peel that onion back and say, okay, now we're ready to take on the next piece, and we're ready to take on the next piece, and we're ready to take on the next piece until maybe you own all of the end-to-end solution. But I just think that's something that Dr. Rucker had a great slide with the architecture there. And I think you can use that as picking off the things that payers have to do versus things that make sense to outsource for the time being. Okay, TEFCA. First of all, I've been involved with Sequoia for 8 years, and I joined Sequoia as the very first payer representative to the Sequoia board and the Care Quality Steering Committee, to really be the representative there, to be pushing forward payment and operations type use cases and try to help them think more broadly than just treatment. It's been a long 8 years. I just, that's true. It's just there. We are just now, after all these 8 years, beginning to really think about how do we become truly operational for payment and operations. And so to that end, I think we're going to get there. I think TEFCA is going to be a potential source for payers to connect to payers and for payers to connect to providers, but it's not going to be there for payers in 2027. So from my perspective, I think I've got to have a short-term plan and keep plugging away at TEFCA and requirements that payers need and the payment and operations use cases that they could be very successful with. But just know that that's going to be a journey, and you're going to have intermediary plans for how you're going to meet these rules of 0057 while TEFCA is developing and beginning to move from not just treatment, but to supporting payers with payment and operations.
Thank you. That's very helpful and insightful. Bob, you were nodding around some of Nancy's comments, and I'm interested in, the CMS 57F rule requires the peer-to-peer exchange be done with FHIR. There's no implementation guide specified. There's nothing necessarily very specific about it, but it has to be FHIR. That's what we understand from CMS 57F. And we understand from Nancy, and I think this is probably shared among many in our community, that the TEFCA and the QHINs are not going to be there in terms of that kind of exchange in 2027, 1st of January. What are your thoughts about this intermediate strategy and about how health plans, especially the small to mid-market plans, can combine, what you need to own and work on yourself and what you need in the near term and what you can work with partners and invest in relationships for the longer term? What are your perspectives on what Nancy just shared? And you're on mute if you're about to speak.
Thank you. It's a really interesting question. I mean, I nod because Nancy's been at the ground floor of this and has been helping a lot of people gain a broader understanding. And for me, my experience co-chairing this committee with Sequoia really brought home, despite efforts from folks like Samantha and AHIP on, you got to think broadly about the industry on some of these things, that smaller intermediate players are going to be challenged by the lack of infrastructure to support this, right? So you're talking about having to go connection by connection. We're in Evernorth, we have the resources, so we're ready to engage in that if that's what's necessary. But the reality is, if that's what's going to happen, it's probably not going to be an effective implementation, right? It'll be just a few critical spots that we'll cover because we have to. But an endpoint directory is going to be critical to enabling this to be done at scale. It is FHIR, right? That's what's been specified. That's great. I think it's a big step forward to introduce this technology in the right use cases at the right time, demonstrate its value to help move everybody along, right? We're going to be dealing with this hybrid FHIR and IHE type infrastructure for exchange for a very long time. So this is really well timed. Just it's a lot, right? We've got the pair to pair. We've got the prior authorization rules, which are also FHIR rules that are going to be driving a lot of change in the next 2 years. And so the focus has to be on, as Nancy outlined, what is it that you must control, right? What is it that you must have the ability to have your fingers on, and then as appropriate, everything else, look to partners in the industry. I think that's going to be the most effective strategy for most of the payers in the marketplace.
Thank you. John, in your perspective from CenCal, what are you looking for in the way of help? What are you looking for in the way of outside support and collaboration that will give you some of the benefits that are eluding smaller to mid-sized plans? What are some of the things that you're thinking of that CenCal can do to get more leverage, to have more partners, build a community approach to solving this very complex problem?
Oh, again, it goes back to the continued discussion. The endpoint directory is, the FHIR, is built where you have the URL that says, hey, I want to direct to this location. And when you do payer to provider, you have the name of the individual you want to exchange a record. So the infrastructure is there. The problem is just where's the directory to redirect, and basically where you set up one connection and you can publish and then have it routed like a clearinghouse. So, this is, that connectivity is critical, and I'm doing work with our QHIO. California has the data exchange, so currently reaching out, and providers are having a hard time. So now you got auth, you got not just peer to pair, but you got auth, FHIR, you got pair to provider. A lot of mid-size providers, even the large, have a hard time. We have a whole team doing outreach, working to connect our providers to our QHIOs so we can have exchange of this data, and then with a FHIR requirement coming. And that's also something that needs to be considered. It's a long haul. Payers, you're going to wind up facilitating that, where it happens today. Hey, we need these, what can we do to help, with money, with resources to get them connected to the QHIO to share. And then they can pick and choose. So in California, we have 7 QHIOs they can connect to. And then they're all supposed to talk through the QHIN. And then the QHIOs are supposed to connect to the TEFCA. So we can solve the TEFCA problem by just having that local connection or that state connection. And then how those hubs, the spokes, talk to each other. But again, when you start talking auth to a payer, when you start talking provider payer, neither side, mid-small payers or providers, can support that.
Okay. Well, that's sobering news. We need to think about what would be required to support these smaller payers. TEFCA is is the national model. But as we talked about before, I'm sure, Nancy, there's a bit of swimming upstream, getting, the health plan perspective within the TEFCA universe understood for payment and operations, and acting on equal footing with providers with respect to using these national networks. Um, Karuna, in terms of the association, if you were to come back to regulators, this new administration, and say, we don't know exactly what you're going to do. We don't know exactly where your head is at. We're expecting surprises, but this is where we think the puck is going to be, if you will. This is where we think the industry is moving. What are some of the things that you think we need to consider as an industry as we change administrations, as we change secretaries, as we change, the folks manage, running CMS, ONCA, STP, the organizations with which we're close? What would be your list of priorities, given this new administration and given this new sort of as yet unknown the future with respect to working with regulators? What are your thoughts?
Sure. And full transparency, there's another team at our organization that definitely is responsible for that. I'm on the technology and plan implementation side.
Sure.
But from the point of view of the folks on the ground there, I definitely will say, top of mind, definitely the National Directory of Health. I think there's a lot of progress and promise there. So I think just getting that out of the way will really move the needle in the way that we need it to. I think a lot of the folks on the panel have brought up really good points around the difficulty to actually embed into the workflow. And so a lot of the APIs with the provider pieces and kind of retrieving that data has been established in the provider community through the national network exchanges. We are actually participating on the board of eHealth Exchange as well as the association. So hoping to have similar conversations with that national network exchange as Nancy is with the care quality folks, to really understand what are the barriers to sharing data with payers so that we can have that kind of longitudinal clinical data record that's meaningful to our members that they can then access from third-party applications. I think CMS really has the vision of consumerizing healthcare and putting patients in the driver's seat and really having that empowerment. How can we kind of work backwards from there to make sure that we as payers are doing our diligence to get the data that we need? And obviously we need the partnership of the providers. So I think what we're lacking is a network effect to scale. I think with a few policy pieces, payers are scaling the learning curve of trust frameworks. We're not super familiar. We generally do point to point. So we are working to kind of adopt that understanding of that paradigm. So I think the policy and the legal and the technical pieces are really coming together. And what we're missing is maybe just the incentives that were touched on a bit. You really need to invest and incentivize the adoption in order to see that network scaling effect, which you even saw in social media. There were incentives to get those platforms off the ground as well. So I think that's something that the regulators and the policymakers may see opportunity in.
Thank you, Samantha. Putting your policy hat back on, and in the area where you specialize, what are some of the things that AHIP and your members are thinking about and working on as this new administration comes in with respect to, interoperability writ large, but also this ability for a patient's health plan information to follow them and to be available to them? What's on your list of recommendations to this new administration? What are the things you think should be prioritized?
Sure. And I think this is a really unique space because these rules, starting from the original CMS interoperability rules, have spanned administrations, right? They've started in one administration, they followed into the next. So I think we're likely to not see a ton of divergence potentially in approach, but we do think that there's a lot of opportunity in terms of continued support from CMS and then other areas impacting interoperability. So I really appreciate Nancy's comments on TEFCA. It's something that we spend thinking a lot about and talking to the folks at Sequoia about is really how do we create those high value use cases for health plans to really get the participation, because I think we do think whether it's cyber recovery, for instance, right? Or it's the APIs under the CMS interoperability rules, or on and on and on. There's so many potential use cases for TEFCA, but the value proposition just isn't fully there yet. And I think there's also some concern about the current allowance for fees, right, in TEFCA to be charged to health plans, and how is that potentially creating a barrier because so much is unknown there. So that's another issue, as Nancy pointed out, I don't know that we'll be there in 2027, right, for it to make a meaningful difference, but we see a path forward, and that's a huge issue that we're working on. And then I will just say, I think these continued conversations about whether we need to relook at timelines or some enforcement discretion or whatever it happens to be, particularly around those less resourced plans, and continuing to sort of we have these conversations at least twice a year with CMS, and more often than that, because they are genuinely interested in sort of the touch points of where different parts of the health plan, ecosystem are in terms of their implementation. So continuing to sort of bring that story and have that information sharing. And then just because it's one of our favorite subjects, I will just put a +1 in for National Directory. We need Congress to fund it, and we need it to be developed.
Nancy, thank you, Samantha. I appreciate your perspective on that. Nancy, you're sitting at the table and have been for close to a decade with Sequoia, which has had an uncomfortable or at times awkward relationship vis-a-vis health plans. Whether it's treatment payment operations, whether these QHINs are designed for provider to provider exchange, whether payers are going to actively be engaged in this. And we have an administration's coming in taking somewhat of a more of a state's view, a federalist view, if you will, of pushing these kinds of technologies and this kind of exchange and this kind of innovation to the states rather than investing in these major national networks. Are you contemplating or considering in your role with Sequoia or your role at Medica and your involvement in this industry that you may be working more locally than nationally? And does that rear its head for you, or is that something that you see coming down the pike?
Yeah, it absolutely does. And John can probably speak a lot to this too from his experience in California, but especially as a payer that supports a lot of Medicaid plans, when you have, one of the things that doesn't work well in interoperability is requirements that are specific to states or plans or lines of business like Medicaid. And that's absolutely front and center with just about everything we do, to say how can we build a platform that has the basis for everybody, but knowing we have to have all these one-off things for states. So I certainly support, from an interoperability and data perspective and fire perspective and all those things, how can we really embrace the standards and use them across the board, so that's the only way all of this is going to work in the end. So yes, very much so. I do think that there are, I think TEFCA, there's so many things that TEFCA can do for us. They just have to have time on their journey to get there, right? So the National Directory is something they've talked about. Member identification is something they've talked about. Being a more of a partner for payers, whether it's payer to provider or payer to payer. And so I think one of the things I would love to see happen more from a new administration or whatever is really open the minds and vision of everybody to say, what could this be? And what are some of those core things that we could really be focused on that would really be building a groundwork for all of the different things we want to do. I don't know how much more time we have, but I did want to mention something we haven't talked about yet, and that's the business use case for all of this. So I think when somebody mentioned that payers, the fees is an issue. I don't really believe many payers are going to have an issue with the fee. because we've been paying a lot of money, millions and millions of dollars for many years to get clinical data. So having something that's more, actually, it's likely going to be less expensive for us to have a solution like TEFCA and pay the fees than what we're having to pay today to get all this clinical data. So I don't see that as really a barrier for payers. But to do, whether you're paying other services to get you medical records and clinical data, or you're paying a QHIN and TEFCA, you still have to have a value. So I think one of the things we haven't talked about today is the continuity of care and how this payer to payer. And that's one of the things our work group kind of struggles with, because nobody's measured it. And so how do you start, and how do you get a ground level measurement that you can see that you're improving from? But that's one of the things that we're going to focus on in our second phase of our payer to payer work group. And that is, okay, you have the data now, payer. What are the different kinds of things you can do with it to add value and to Samantha's point, pay for the solutions you're having to build? And I think that I'm really excited about what this information is going to do for the member experience. Knowing that me as a member, and I take a couple of medications, and if I change plans, all that having to start over again, everybody's always very anxious about how long that's going to take. This kind of solution is going to help the continuity of care and the quality of care. In my opinion, it's going to be immense. And so I think we can't lose sight of the value here. Lots of challenges, lots of things to get over, lots of decisions to be made. But in the end, the value to healthcare in general is going to be, in my opinion, significant. So we just need to keep that in front of us.
Terrific. We need to wrap in just a moment, but I want to ask, starting Bob with you, and then John and Karuna and Samantha, to share also, as Nancy has just done, your 30-second. This is what I would like the community, the WEDI community, to get out of this conversation and to look for in the future as a priority. What would you say is your takeaway that you would want to leave with the members of the WEDI community?
So the takeaway I'd love to leave is the thing we didn't really address, right? Which is the value in this data and the ability to exchange, right? We talk a lot. There's only 2 years to go until we get to having to be up and running with this. So there's this press to talk about all the scary things we have to do. We don't want to lose sight of the fact that this is an incredibly valuable way to improve the experience that our members as payers have when they transition care from one payer to another. Which, if you're an ACA exchange patient, happens every year. It's an incredible amount of turnover. To be able to smooth that transition and to give the plan the insights on how best to deliver value to that individual is tremendous. This is not a compliance checklist item. This is something that we should be embracing as an industry, as an opportunity to really improve the care we're able to enable.
Thank you. John, what would you like to leave us with?
It's like I was saying earlier, it's like the endpoint, being able to have have an endpoint solution, or I mean, there's a need, so somebody's going to want to do it, because somebody's going to pay for it. But it's also an education. Now I'm doing a lot of work. We should be doing APIs from providers to payers now, just even to connect to the QHIOs. That information needs to be out there and educating the entire industry. I bring it up and it's like, oh, we're doing extracts. So I'm like, well, you're doing double work. You got to do this anyway. So that's a big thing too, is just getting the word out to the provider community, not just to the payer.
Thank you. Karuna, parting thoughts.
My takeaway for the group would be this is definitely happening and not going anywhere, and agree in terms of independent of business value. This is a huge opportunity to build trust with members and patients. So I would encourage folks to get involved. I think all the pieces are there, and it's really about amplifying what's working and what's not working. Besides Da Vinci, there's also the FAST incubator under the HL7 umbrella, and they're really pioneering that National Directory of Health work, getting involved with things like Trebuchet and the various QHINs to understand kind of what their product offerings are and be able to bring those insights back to your organization and bridge gaps is really going to be critical to driving this to the home. Thank you.
Thank you. Thank you. And Samantha, lastly with you, your parting
Sure.
thoughts.
Very quickly, I think it's having conversations just like this, where you're creating kind of a continuous learning community. I started my health IT policy career, and this will date me, September of 2008, about 3 months before the passage of high tech, right? There was a long period of time with the implementation of EHRs where no one thought it could happen, right? No one could have imagined sort of where we are today. And I think that there is room to resolve these issues. There's room for us all to work together and to really realize that value for patients. So the pain points are real, and we just have to start picking them off one by one.
Well, Nancy Bevan, Bob Oakley, John Raskowiak, Samantha Birch, Karuna Welwani, I want to thank you all for joining us today and participating in this piece of interoperability, of which 3 more segments are going to be presented subsequent to this. Thank you for your insights. Thank you for your perspectives. And Michael, I will turn it over to you.
Thank you, Denny. And once again, a fantastic job as always moderating. Yes, Nancy, Bob, John, Samantha, and Karuna, thank you very much. You will hear from Nancy, Bob, John, and Samantha later on some other additional panels. It's my pleasure now to start the Provider Access API panel with the moderator, one of the co-chairs of WEDI's Prior Authorization Work Group from the AMA, Heather McComas.
Thanks so much, Michael. And I see the panelists popping up magically on my screen. Thanks so much, everybody, for joining. And particularly, I know we've had some last minute switcheroos on our panel. So I particularly appreciate folks for being so flexible today and joining us and participating in this panel. I will first I'll give a couple kind of introductory requests to our panelists today. First of all, as I kind of pitch the first question to you, if you want to go ahead and take care of introducing yourself and explaining what you do at your organization before you kind of answer the question, that'd be great. And then also, I just want to invite everybody on the panel to see this as a conversation, and please do not wait for me to ask a question. If there's something that someone else says that you would like to jump on and pick up in the stream of discussion, that'd be great. I really hope that we can have a conversation here today versus having a very structured, formal discussion. And then one last thought, it's come up already a couple times since the beginning of this event. We heard both Dr. Rucker and also Bob Oakley on the last panel, as well as many others, highlight the fact that they really are hoping that these APIs are more than a compliance exercise for all of us, and that we all really see this as an opportunity versus a check the box kind of activity. And I think this is, in my point of view, this is particularly important with the provider APIs. I hope that payers are not going to just build these things and then they're going to sit there and not get used. And so I really encourage all the panelists to talk about during this discussion today, how can we really ensure that providers actually use these APIs once they get built? What is the actual value? What are the potential kind of low-hanging fruit use cases that you envision either your members using, your clinicians, if you're actually in a provider organization? Certainly from the health plan perspective, Samantha, I'm hoping you can talk about, what you're hoping your members are hoping that providers will be using these APIs for. So anyway, thanks so much everyone for joining. And I'm going to kick things off from the association perspective. And Terry, maybe you and I can kind of pinch hit here because I'm speaking a little bit here on behalf of the AMA and also acting as moderator. But Terry, first to you from the AHA's perspective, what have you been hearing over the past year since the rule came out from your members about the provider API? And what do they expect to achieve with the health plan data that they haven't been able to do so far without this data? And are you providing any guidance to your hospital members so far on this API? Go ahead, and then I can pipe in from the AMA perspective.
Sure, and I'll follow your previous direction. Hi, I'm Terry Cunningham. I'm one of the pinch hitters on this. You guys lost the opportunity to hear from my colleague Andrea, who's out sick today. I am the Senior Director of Administrative Simplification Policy at the AHA. In terms of your question, I think in terms of what have we heard from our members and what have we done to kind of pass this along to members, I think our members were excited at the prospect of just having better access to clinical data. I mean, I think the ability to have a more clear understanding as to what your patient's care history is and kind of things that might impact any care decisions that could be available through this type of information sharing is a really attractive possibility. In terms of what has been done and what are we doing, I think what we've been messaging is to kind of get the word out and tell them to talk with their vendors on this issue, just to, we're still a bit away from the date in which this goes live. And so in terms of specific programs, I don't think we've gotten to that stage, at least with us communicating with our members, but we have indicated, this is the capability, talk with your members, see how they plan to incorporate this into kind of what you currently do and how does this fit into your workflow, things such as that. And so that's kind of how we've approached it to date. I don't know if you had anything to add.
Yeah, thanks.
Did I answer?
I totally agree with that. And I'd be curious, this is Heather maybe editorializing a little bit. In terms of what we've been hearing from our members about the rule as a whole, I think honestly, a lot of the attention from the physician perspective has been on the prior auth API, to be honest, I think, and not to just the provider APIs at all, but I think, in terms of what is a major pay point from our physician members, it's prior authorization. I think this one is not getting as much attention, and hopefully as we get closer to the implementation date, it will get more interest from our members. But I think that prior authorization is such a huge burden for physicians and for patients that a lot of frankly, the air out of the room has been sucked up by the prior auth API so far. So thanks so much for that. I'm going to now move on to our actual live provider representatives who are actually working in provider organizations. Anna, I will start with you and ask, what are you thinking about and in hearing your organization about the API in terms of how it fits into the strategy of your organization, and what benefits do you see both for your actual clinicians and actual for patients too as well?
Got it. Sorry, the mute button didn't want me to select it. Thanks so much, Heather. I appreciate that. And I will also follow the introduction cue. Hi, everyone. I'm Anna Taylor. I'm the AVP of Population Health and Value-Based Care for Multicare Health System, which is up in the upper left corner of the U.S. headquartered in Tacoma, Washington. Well, we're a medium-sized health system. Mainly, our footprint is in Washington State. We have about 13, 14 hospitals, some of them in the mix of integration. And we are really thankful to be able to share this story with you and talk through these questions. So as far as the provider access API goes, the adoption of that has been hard to get payers to give us the data. They're not ready. I just got a contract from a big national payer that said, no, I want to exchange data using documents and CCDs. And we're ready for that FHIR implementation, for that API ingestion. And I'm still getting documentation and the legalese that doesn't enable us to utilize those services. So having to go back and forth around managing the administrative pieces that also go along with implementing a new technology is something that's proven itself to be a real barrier in implementing these processes. The adoption of the prior auth API, we were the pilot. The National Standards Group recently released the report on our experience for the prior authorization, so you can look for that email, and it snuck in there amongst all the other exciting news from DC. But I have to say it's very thrilling to read through a report on how prior auth is going. But we have been piloting this capability, and for a very long time, providers have wanted something better. And this is really going to be that better. And we're really excited to get more payers to implement that. There's a lot of work to get done to get from point A to point B to get that to scale.
Thanks so much, Anna. I really appreciate that. Samira, I'm going to throw the ball to you, and hopefully you're ready to get off mute and catch it. Same question to you. What are you hearing at your organization about the provider API, and kind of what are your hopes and dreams for both clinicians at your organization and also for patients in terms of how it's going to improve care?
Thank you, Heather. I love that. Can you all hear me okay? Okay, perfect. For whatever reason, Zoom doesn't always work out on my end. But hi, everyone. My name is Samira Singh. I'm the Director of Interoperability at Providence. If you are unfamiliar with our health system, we're a very large health system spanning 7 states, 51 hospitals, hundreds of clinics. We have a ton of value-based care contracts. So I would like to take what Anna said and say I completely agree with all of that. But I'd like to take a little bit of a different spin on it, because if you know me, you know I'm very passionate about value-based care. And so my answer will include some of that. So when we think about the provider API components, we always split them up into 2 separate sides, right? There's the sharing of the clinical data, the same information that we would share with our payer partners out of our EMR, plus the sharing of the claims data. And if you all haven't looked at the PDEX implementation guide recently, you will see that there have been components added around sharing financial data and urging payers to share financial data as it pertains to claims, even if it's not mandated, if the relationship dictates that it's available, right? Or if that data is available publicly. And so to your question, Heather, around what would we like to see and where are we at right now? So I agree with what Anna said. Where we're at right now is payers are not capable or able to share the data right now, right? Most of our payer partners, to the point around prior authorization, are also focusing on meeting the prior auth mandates. Most of them are targeting the 2027 deadline. However, there's state mandates where some of the target dates are, or willing, Marchand, some of the target dates are 2026. And so we spend a lot of our time talking to our payer partners. We believe that in order for interoperability to be successful, you need to have the right people at the table, right? And how do you get the right people at the table? Well, you have value-based care contracts, you have fee-for-service contracts, you have relationships that you foster and grow. And so what we've done over the past few months is had a lot of honest conversations around what can we support, right? Can we support data exchange through provider access? Can we work on other value-based care use cases and so forth? And a lot of what we're hearing is, our resources are strapped. We don't have the technology to support this right now. There are no incentives to support this right now. And that's just the reality, right? Prior authorization is important. There are a lot of use cases that are extremely important. And so we just have to meet the market where it's at. But to your question of what we would like to see, we would like to see all of our payer partners in our networks start out with a claims component. Because the clinical data, there's this heavy dependency on your EMR, right? And what happy path your EMR takes integrating the clinical data back so that your clinicians have it within their workflow and so forth. But the claims data, especially if you have value-based care contracts that have a total cost of care component that has a heavy impact on your bottom line, that standards-driven claim line level information that you can get through a standardized API would be an absolute game changer, especially if it's real time, right? You're not waiting for a financial report at the end of the year to tell you that you're losing $2 million. You have access to more real-time information with financials, hopefully unmasked data, to be able to feed that to your downstream analytics teams and to be able to have actionable insight. And so that's one thing that I think we as providers would all agree on we would like to see, because that's also something that we have control over, right? We're not waiting on our EMR vendors to build out the technology. We can retrieve that data using Postman if we had to, and then integrate it downstream and then make it available to the right people as soon as possible. So, I mean, we can dream, right? But the other use cases that you mentioned are extremely important as well. So, and conversations like this are super, super important to getting people involved, to getting them aware of, where there is interest and where there are opportunities for partnership as well.
Thanks so much, Samira. And yeah, I totally agree. I think that these kind of conversations that WEDI's been scheduling kind of periodically since the rule came out are really important, because I think it gives us all what I see as reality check about what's actually happening out in the world. Like this rule got published, right? There was kind of a 3-year lead time. So, and my staff, I know they go a little bananas. I keep saying this is, there's less than 2 years left, blah, what's happening? But I think it's really important. Like, are people exchanging data? Are we ready? And it's kind of like, man, not so much. And I think we have less than 2 years. It's not a disaster yet, but like, it's a good, it gives us a good understanding what's actually happening out there in the world. And with that, I'm going to turn things over to Michael. I already saw that Michael chimed in the chat, which is great. Michael, I wanted to talk to us a little bit about who you are, where you're from, and what you're seeing going on right now with Sutter in terms of implementing the API, and kind of what your hopes and dreams are for clinicians and for patients, and basically, again, what's the reality check of what's actually happening, boots on the ground right now in your organization.
Yeah, and no, I appreciate that, Heather. And I'm just gonna take a quick step back. So first, I'm Michael Marchand. I'm the director for interoperability and community connect at Sutter Health. We're a large IDN in Northern California, and really my path through the APIs and 0057 and Da Vinci and all those different things, and Fire APIs overall started a long time ago with HL7 and HIMSS and a lot of different organizations that I participate in, Care Quality Advisory Council and things of that nature. But just to take a quick step back, APIs are available. I was at UC Davis before I came to Sutter, and at Sutter as well, is we are exchanging millions of Fire resources on a regular basis with multiple partners to include our patients who are requesting their records through our EHR technology. So the Fire plumbing is there. The endpoints are there. People know how to find us. People know how to get data, request data from our organization, and that's happening on a regular basis. And again, I could give you reports of millions and millions of resource calls that are happening against our current EHR environment. I think the big thing as we move forward, and if you think about today, we are connected with payers. If we weren't connected with payers, we get no claim, we get no payments, we get no enrollment files, right? But what are those processes that are in place today, and how do we replace them with Fire-based interoperability to have more real-time, web-enabled, functional interoperability with our payer partners? And again, each organization, from a provider organization standpoint, is we're contracted with, let's say, and I don't know the number, but let's just say 30 payers. So that's 30 endpoints that we need to discover and connect to. The question becomes, is the payer ready to handle that traffic? And we'll use prior auth as I'll call it a simplified use case from my perspective. I know who the patient is. I know who the payer is. I know what service that I'd like to have authorized. I can send that request to a payer today, multiple payers today, if the plumbing was there. The problem or the question is are the payers ready to respond? Put endpoint discovery on me. If I want auth to work, I'll find your endpoint, I'll register for it, as long as you can handle the traffic and respond in a standard way. And again, to leverage Da Vinci and the Da Vinci implementation guides, that work has already been done. I've completed 3 pilots in different ways to include direct integration with Centene, between our HR and Centene, to do auth in an automated way, in a direct connection with with all the fire accoutrements. And I think that are the payers ready to handle that payload? Can they respond to the 7,000 different contracts they've written with different rules and requirements based on what employer group or how that patient, what plan that patient's in? And I think that's where at least from my perspective, and again, I've been on the provider side for a long time, so it's probably they're probably a little shaded in one direction. But I think I don't know whether the payers are ready in mass to handle that sort of activity. Is because if from a provider perspective, if you said, oh, here's our endpoint, go self-enroll, here are all the transaction types that we support, I'm sure all of us who are patiently or impatiently waiting to do this work would go enroll and start sending requests today. But it's the other side of the equation, or at least that's how it feels. And again, I would love for our payer partners to jump in and tell me where I'm wrong there. But I think that's really where the rubber meets the road. Is we're all chomping at the bit to move this along. A lot of us have lots of investments and lots of technology in place to support these types of transactions, and we're just not finding that sort of energy and support on the other side.
Thanks so much, Michael. So before we get that plan perspective from Samantha, I'll give her a couple more minutes to prepare herself for the plan side response to this. I'm going to go to Arun from DaVita and give us DaVita's experience so far with, getting ready for the provider API, what you're seeing in your organization, and kind of what you are already seeing as benefits for clinicians and patients, and what you hope for the future. Go ahead. Thanks.
Yeah, thanks, Heather. And again, I think this is maybe the benefit or the curse of going last, because the talking points are already covered. But just in terms of introductions, my name is Arun Gopalan, and I am part of DaVita, and I'm a senior director for interoperability. And I'm also part of the coordinating committee of the eHealth Exchange. So interoperability is an area that I really love being involved with. So in terms of where DaVita is at, or with in terms of where we are talking to our payers, I think very similar to many of our panelists, you're already in contracts with payers that have certain data requirements and data sharing infrastructure that you continue to build on, while having this future facing conversation of, hey, we are ready when you are, right? So that's kind of where we are. And so I think just in terms of DaVita, the challenge that we have is we are a national provider and we are also a specialty provider. So you need both the breadth as well as the depth. And so there is just like a lot of things we can do with an API infrastructure like this, and then we are really interested to kind of move forward with this.
Yeah, I'm really glad you brought up that point. Kind of as a specialty provider, things might be a little bit different. You're kind of at a more narrow focus. So I'm glad that you referenced that, Run. So given the providers a chance at the mic, Samantha, I'm going to turn it to you and kind of get your perspective on what you're hearing at AHIP from your plan members in terms of the provider API implementation. You're hearing, frankly, from the provider side, they are, I believe Michael said, chomping at the bit. I believe that is the quote, chomping at the bit, ready to start sending these queries to the payers and getting data, and they're kind of getting kind of a closed door there. Realizing that the effective date for this API is compliance is not until January 2027, but what are you hearing from your payers, and what value, I think, from the payer side do you see? Because I think that is something, I've seen some things in the chat, are you going to build this and no one's going to come? We're hearing from the providers, there's some real eagerness to use these APIs, but what's the plan perspective on all of this? Go ahead. Thanks, Samantha.
Sure. Appreciate the plan perspective being added to this conversation. And I couldn't possibly address sort of all of the comments that came before, but just to introduce myself really quickly, I'm Sam Birch. I'm the VP of Technology Public Policy at AHIP. I started my health IT policy career and have largely been actually on the hospital side. So prior to coming to AHIP, that was my perspective. So certainly not surprised to hear in any way the previous comments. I was actually at AHA sort of in the very early stages of the proposed rule. So I think the first thing that I'll say is, I think that plans are not addressing, sorry, that's my dog, are not addressing, one second. Sorry, are not addressing this in a vacuum, right? I mean, it is the full scope of the rule that we're working towards implementation on. So that is obviously all of the APIs. I think in terms of goals, we support the goal of this. We see the benefit for providers in terms of, running metrics and supporting a more complete picture of the patient and all of the things that have been brought up previously. I think in an ideal state, though, we would like to see this exchange be bidirectional, right? To support our care coordination, to share data for quality measurement, to support case management, and to be proactive with ADT notifications, all the things that we hear about our members in terms of bidirectional data. And I think, to the comments that have been made about, it feels like plans aren't moving forward on this, I can assure that they are. I mean, the conversations are happening every day about the resources that are being put into building out these APIs. And we are Still again, 2 years away from the effective date, and having come from the hospital side and seen the early stages of EHR implementation, nothing happens exactly when all sides of the ecosystem want it to. So the work is very much underway, and I presume we'll have time to address barriers, but we certainly hear about a set of challenges, right, that are sort of impacting and not necessarily even slowing down, but that are just considerations and challenges as payers work to build these.
Yeah, that's a great point. And actually, there's something Janice already put in the chat about. I think it's maybe one of her favorite questions, and I'd like to get to that. But Samantha, one more question from you that I think it's come up a lot with the provider, with the patient, the prior authorization APIs. But have you heard from your members yet if they are going to be building out the provider API across all their lines of business, not just the impacted payers and the rule? Because I know that's something that's really of interest to providers. I mean, ideally, they would love to be able to use the API for all types of plans, not just those in scope of the rule. So is that something that you're hearing about, and realizing that might not be their top priority? There's a lot they need to do, understandably, under scope of this rule, but is that something that's been discussed so far that you're aware of?
Sure. I haven't heard anything definitive enough to sort of generalize on how I think plans are approaching this. I think the strategies will be different. If you listen to the last panel, there's obviously some sort of significant variation in approach between our small and medium-sized plans and some of the larger payers. So I expect that could potentially look different. But I think that the goal at this stage is to sort of be trying to overcome some of those barriers to get to the implementation date.
Sure thing. I think it's a great idea to talk about potential barriers, and I think, to my mind, this is a challenge / barrier / question. And Janice, I know, and Karen has raised it in the chat, and it's come in other discussions. How do you think plans are thinking about establishing if a provider has a relationship with a particular patient? I know that's been a kind of ongoing question. It's kind of left outside the scope of the rule. Is that something your plans have been talking about, Samantha, and what kind of other challenges beyond that are you hearing from the plan perspective in terms of how to implement these provider APIs?
Sure. So I think that they are thinking about it and working on it, right? How much they're talking about it, at least with us, is that the specifics aren't coming up in conversation, but we know that this really is sort of something that is a huge challenge, right? And I think that this is across some of the APIs. And so other things we hear about are, obviously how to facilitate the opt-out, right? Because that is just a fundamental challenge. What's the attribution model? To some of the points earlier. I mean, even if this is so outside of just sort of identifying the provider, if this is a HIPAA covered entity to HIPAA covered entity exchange, there's still the imperative to ensure that sort of members understand their opt-out, right? And that we're respecting their patient preferences, right? So when you look at how to operationalize sort of the tagging around who gets the patient's data in terms of providers, is it every provider they've ever seen, right? Is it their primary care doctor? Is it the providers they identify? Sort of how, so I think that is one of the issues, that's actively being worked on, amongst many, many others. So, I mean, I have a list here, but I'll stop there.
Can I make a few comments on that, Heather?
Yeah,
if it would be
sure.
okay.
Please go ahead.
Okay. You did say to interrupt when you wanted to chat.
Absolutely.
Sam, I love what you said on 2 counts. The first one was we need a bi-directional data exchange strategy between payers and providers, right? I wholeheartedly agree with that. And something that we do at my organization is that when we engage in conversations with our payer partners, whether we have value-based care contracts, the high performance network contract, whatever it may be, right? we always say that member attribution is the baseline for that. Because for what you had in your second point, both the payer and provider need to have a full and complete understanding of who the members are, whether they have been assigned to a practice, a clinician, an organization, whether they've been attributed through claims, whatever it may be, right? So what we always offer in these conversations, and what we typically have in the legacy framework through like flat files and Excel documents that we get through, SFTP servers and stuff like that, is we have a way to exchange who those members are, right? And then we have a way to exchange that in FHIR through DaVinci's ATR implementation guide, right? And so on that first front, we always say, let's make sure that we're of the same understanding, whether it be your value-based care contracted measures, or as one of our old teammates used to say, all the patients that have a size 10 shoe, like whatever the criteria is, right? That fits into the ATR framework, and it fits into the way that you exchange who those members are. So I completely agree with that being the baseline. And I completely agree with that also being the starting point for clinical data exchange from the providers to the payers, right? We at Providence use CDEX and bulk to be able to share data for the quality measures that are part of those value-based care contracts. That is absolutely a good starting point for payers as well, because one of the burdens I would imagine is, how do you take this data? How do you parse it? How do you build your FHIR ecosystem, right? And it's always a little bit easier to get information that you can then kind of manipulate and say, okay, I have to account for all these things. What does my security model look like? How do I ensure that this data can go down to the teams, that it needs to, and so forth, versus how do I take my entire backend structure around clinical data exchange, map it to FHIR, and then, instigate the process or initiate the process. And so I wanted to point that out, because I feel like you had so many good points around needing bi-directional exchange and starting with clinical, even from the provider perspective, especially if they're on a certified EMR, right? We know that there are a lot of initiatives happening through Trebuchet, through 10 by 10, under the TEFCA umbrella, a good opportunity for providers to participate there. And then scaling out to other use cases, whether that be provider access API, the provider getting access to their clinical data or claims, or something like value-based care performance reporting, where we automate the way that we exchange the financial data, right? This also allows us to be able to share more administrative ASM, HCC-based coding data and so forth. But in order for this to be successful, we absolutely have to build out that bi-directional ecosystem. And the best spot to start is with ATR, because it is simple. It allows you to agree on who the population is. It allows you to have some sort of baseline that says, these are the members that we are caring for together, right? And then from there, you iterate and you build on your use cases and you get more savvy, and then you scale out to everyone else. I won't talk about point to point versus intermediary versus all that stuff. There's another session, but it really does, sound like a good spot to start, and then scale out to everything else that you've mentioned. And it does also help both sides bust down some of those barriers that you talked about as well to adoption, right?
Yeah, can I just add to that? I think one point I just want to reiterate, Samira, you said it beautifully. I think it is not just 2 years away, right? That there has to be a path for us to get there. And I think that is what all providers are hoping to get from here. How can we play together till that deadline and not kind of wait for that and do everything at that time? So
yeah, one of the things my co-panelists is that see the gray in the beard. I'm much older and much more skeptical, and some of the provider the previous attribution of attention between providers and payers really does still exist in some organizations. A little bit of mistrust, and I think to build trust, you need transparency, you need clear rules, and I think that we haven't talked about TEFCA, but I think that part of our HIPAA-based exchange. Janice made a comment. For what it's worth, proposed rules should strongly encourage patient to have consent. At this point, because it's TPO, there's no additional need for consent. But I think that transparency might be the way, and it's been talked about in a few sessions I've been to before, is there a way to allow the patient to be aware that something's occurring? Because there's so much exchange today that happens in the background for lots of different reasons, whether it's Samira's Excel spreadsheets or whether it's, centralized through claims processing, or whether it's some other process. There's a lot of data about patients that's exchanged today for many different reasons that they are completely unaware of. And I think that maybe some movement forward in the transparency area also might help, not only in the trust relationship between payers and providers, but also in incorporating into that trust relationship the patient, who's ultimately should be involved and aware of what's going on. And today, they are for sure not.
Thanks so much. Just to maybe kick it out for Terry and Anna to chime in with any thoughts on barriers to adoption you're hearing from your members or expect from your members before we move on.
I mean, I think the main, you've kind of heard them throughout this discussion. I think it's barriers in terms of adoption. I think providers can only use this when plans are ready for the information sharing to occur. So there's not necessarily the appetite to adopt it if it's not usable at this state, I think is part of it. Additionally, I do think there's concern with waiting to see how widely, and again, this is just kind of related to ROI, but just how are plans going to implement this? Is it only going to be for the specific plan types that are named in the rule? Is it going to be the broad spectrum? Again, harkening back to a question you had asked. I don't know if I've heard any specific technical issues. I think that's, again, I think it's something you covered in your questions, but I think their providers are relying on their EHR vendors to ensure that the technical piece is solved. And so in terms of are we using it is really when I consider adoption, full adoption on their part. And again, I don't think we're at a state where the plans are ready to use it. And so in the sense of adoption in that sense, I don't think providers are doing it just because I don't think there's any advantage with most payers because it hasn't been necessarily built out for real time at this point.
Yeah, and from the provider perspective, I'll just second what Michael and Samira have already discussed. That has my full support. We don't want to be gluing spreadsheets together anymore, but I'm going to come at it from a personal standpoint as a patient, which is I want my doctor to have all the best information to make the strongest medical decision they can for me. That's what I need. And that data does not just reside in the EMR. That's a claim from the naturopath or a PBM or somewhere else, a massage therapist, that's going to bring together the more holistic picture of what's going on so that, medicine is a process of elimination to get to a diagnosis and sometimes never get to one. You just become an N01 that has like, you might be this, you might be that. So it's really important that we are not just thinking about ROI for a business margin, but we're also thinking about bringing all the data together for a better care decision for patients. So I think that's one thing that MultiCare is always thinking about is how can we make a better decision for our patients? And all of these APIs help us get there.
Yeah, and just to add to that, again, from a DaVita perspective of like really vulnerable populations in an ambulatory care setting, I think it becomes even more critical. The timeliness and completeness of data really becomes a life and death situation. And I think it's really critical to kind of also put that patient perspective and see how these APIs could kind of really deliver in terms of both strategy and compliance.
And I think from the plan perspective too, I think that we would agree with those objectives. And I laid them out sort of when I first spoke to this issue, because I think the objectives are largely aligned, right? There's technology that needs to be built and processes that need to be developed and workflows and all of that. So I mean, technology implementation, right? When you start factoring in all of the little issues, it can be difficult, right? So it's building off of what already exists. And, in terms of what we can glean about relationships from claims or from value-based care arrangements where there are rosters, I think plans are using what they have currently and trying to build off of that. And then, ultimately, starting to fill in the gaps. So, I mean, the work is very much underway. And I can say as a brain tumor survivor, I mean, that is the goal, right? For all of the information that a provider needs to treat the patient to be there. And, ideally, as we've said, for the information for the plan to be a partner, right, in that process. So glad to hear, that we all agree on that point.
I really appreciate the conversation, and I'm kind of going a little rogue here off of our scripted questions, but what y'all are saying makes me wonder, do we think that there is going to be, and maybe this frankly is going to fall on part on the AMA and the AHA and kind of the association level, but is there going to have to be a shift perhaps even in the way our clinicians think about getting their patients records? Because I'm just thinking, again, this is just Heather, not really speaking on behalf of the AMA. I don't know if you're, average physician today practicing in Evanston, Illinois, where I am, is going to think, oh, I'm seeing Heather and I need to go to her insurer to get her records to get the whole picture of Heather's medical care. I just don't think that, I'm just being honest, I'm not sure that most run-of-the-mill physicians or their support staff are thinking, I need Heather's records. They're going to go out to, frankly, North Shore Connect, which is kind of my umbrella where I am right now, or they're going to think I need to go, to other providers that Heather's seen, but I'm not going to go to her insurer to get those records. And are we thinking these are workflow changes even? Are you thinking at your practice setting, you're going to have to be talking to your clinicians and their nurses and their medical assistants and their support staff to say, hey, go use this new API and ping Heather's payers to get her information? Because I just don't know if that's the way that folks working in the clinical setting today think about getting other records. I'd be really curious what y'all think about that.
Can I try this one?
Yeah, and then I'm next, Samira. I'm after you.
Okay. Just because we've had these conversations, initially when we saw that the rule dropped, we thought, how is this going to work, right? How is this different, to your point, than, getting data from an HIE or one of the other organizations that we participate with, or the Community Connect components, or whatever else, right? And so we embarked on a few different conversations. One, we wanted to understand what payers were going to do in this space first, and what kind of information they'd make available, and how, right? And then two, while I disagree that providers' interoperability strategy should be heavily tied to their EHR, the reality is that for a lot of providers, it is, right? A lot of them are not thinking of how do I create an API marketplace so that someone can come in and register quickly and we can exchange data real time and do all this stuff, which if you're a provider and you're not thinking about that, you should. But to go back to your question, Heather, so when we talk to our EHR vendor, what they said is that they have a happy path, and this clinical data shared through the provider access API will be no different than data that's integrated through community partners, that's integrated through other things that we participate in, whether it be eHealth or something else. And so a clinician would essentially never really know. It's just that the aggregation and the deduplication algorithm would essentially prioritize the data shared from the payers at a different level than trusted providers in the community. Right. So from a clinical perspective and getting access to that information, in theory, based off of what was shared with us, that information would be available in regular workflow. But to throw it back to value-based care, because I think this is extremely important as well, there is a completely separate use case, even with the data being integrated back into the workflow. When you think about quality measures that are heavily prevalent within value-based care contracts, colonoscopies are really, really prevalent, right? Like top 3 measures. And what a lot of our payer partners do is they sent out fit tests to their patients to take the place, and do not quote me on how this specifically works, but to take the place of having to get a colonoscopy if the patient qualifies. Do you know what happens a lot of the time on the provider side? We have no idea that test was sent, right? We're not notified. And then all the while, as it pertains to best practices and the kind of services that we offer, we'll go after and we'll do outreach to those patients. We'll ensure that they're getting scheduled, even though the patient received something from the payer perspective that would nullify the need to do that, right? And so when it comes to sharing clinical data and when it comes to sharing clinical data with payers to close quality gaps, we can totally see the value of getting that clinical data back that will allow us to close the quality gaps in our tracking system so that we're not doing unnecessary outreach, so that we can help reduce some of the burden with our outreach teams and determine and help determine that we're only reaching out to patients who actually need our services, right? That we're not calling them and saying, let's get you scheduled for this test if that has already happened because it's a covered benefit through their health plan through some other way. So I hope that somewhat answered the question. I'm sure Anna's going to add much more than what I've said.
That is certainly one of the problems, is not knowing what each other's doing, and we're trying to reduce the inefficiencies in healthcare so that we can push all that dollar to care as much as possible. But so I'm going to put my user-centered design and engineering undergrad hat on from 2005 and say, you shouldn't have to make 18 clicks to go reconcile that data. And I have watched my provider, and in my head, I'm like, ooh, I'm going to count how many clicks she takes. And I'm not watching the screen, I'm just listening, because she had to go get an imaging exam. And it was one with a partner who it was a document, so a PDF that was exchanged. And I'm watching and I'm listening to her click, and I'm like 23, 24. And in my mind, I'm like, I'm just going to stop counting, because this is crazy that it takes so much just to go reconcile that data to the record, that no way it should do that. This is where the promise of our new compute capabilities come in. I think that it has a long ways to go to be automated in the provider workflow. I don't think it's, we don't want to automate a process that isn't working. Like if you're a bad note documenter, MD, ARNP, then if we ambient your bad note taking, it's not going to make you a better note taker, right? So those are things that we need to really look for in efficiencies. But it'll be really important for us as technologists and engineers and system engineers to really focus in on how do we get that data to a usable place in the EHR. And I can tell you right now, the cardiologist does not want to look at 20, I have how many years in my health app on my watch? It's probably, let's see, my kid, so a year before my kid. So 11 years of health data. See both of my pregnancy weights, all that stuff on a daily basis, which is kind of cool. So they don't want to see 10 years of my resting heart rate. They want to see the analysis of that. Like, hey, Anna has an average of 65 or whatever it is over the 10-year period, including 2 pregnancies. That's the insight that needs to be delivered to our providers. And so if we don't start somewhere on connecting, even just exchanging the data, we're not going to be able to use these tools to get to that place. So this is step 1 in a longer journey, but we absolutely have to start, because we're not taking advantage of technologies that finance and other industries are easily taking advantage of, because they have more standardized interoperability capabilities than we do.
Yeah, just a quick point to add, in addition to the workflow stuff that has already been discussed, just from a data sourcing perspective, in spite of us having connection to all the major HIEs in the country and all that, there is still a huge amount of data gap for our patients, not to mention anything about the data quality aspect of it. So I think that's what we are hoping these new kind of opportunities would help bridge as well.
Yeah, thanks so much, Anna, for kind of bringing that up. And I think it's something we hadn't quite hit on before, but the potential for this to create even more just kind of overload on the clinician perspective, like just a bunch of more stuff that isn't really important to look through. And, to Michael's point, the horror movie of the 18 clicks or whatever, it's like, totally love that. That's not the point of this. And how do we actually provide meaningful data to the clinician at the point of care without creating a bunch of more noise, a bunch more clicks? I mean, that no one's going to want to use the API if that's what's going to happen, right? Just, something is like kind of, sifted through, that's really to the point that the clinician needs to know at the point of care. I think that we are close to at time, but I think we have a minute for closing thoughts. I think I'm going to try to go in reverse order that as from what we started off into, so that poor Arun is not left in the same situation where he was with everyone having taken his initial thought. So I will actually maybe start with Samantha, because she was the last person She had to put up with all the provider bashing, and she was very kind about it. So I will let her start off from the health plan perspective, and then I'll go back for the provider and
It's
the
all
office
said with
secretary.
love, Heather. It's all said
Said
with
with
love.
love,
You know
so much
what?
love.
Yes.
Yes.
It's okay. I was the basher, right? for 12 years. So
Go ahead, Samantha. Your kind of closing thoughts on the provider API.
absolutely. So very quickly, I think I heard a couple of things in the last few comments that make a lot of sense. I think we all know that this is going to take partnerships, right? This is going to take everybody maybe working together in a way where we have in pockets in maybe around value-based care, where we've had specific use cases for data exchange, but this is, creating a fundamental shift. And it's, going to be a work in progress. And, I think that clearly making these data usable, right, and actionable is going to take partnerships with the EHR vendors as well. And so the work is underway, and I look forward to having this conversation again over the next 2 years.
Thank you so much. And thanks for giving us the plan perspective. I think it's really important to have it in the panel. Arun, let's go to you next. Closing thoughts.
Yeah, I mean, I think when you think about everything together at TEFCA and this and that, I think it can get super overwhelming. And I think I just take the perspective of let's not get the great come in the way of good. So the incremental progress that we can all make together in pilots or whatever leading up to any such deadlines, I think will hold us all in good stead. And that's what I'm hoping for the next couple of years.
Thanks so much. Michael, 18 Clicks and Beyond. What's your sequel?
Yeah, Keanu Reeves stars. It's like a John Wick spinoff, right? I mean, for me, I think the thing is that the technology is there. I think there's patterns and processes in place to do adoption. And the question is who gets the value from implementing what, right? And I think that, the term misaligned incentives get used a lot. And I think is how do we align the incentives in order to spur adoption? Because there's a lot of providers who believe like we're ready to go. The APIs are there, US CDI is in place. We've got all the regulations. We're ready to do this, but there's not an incentive that I think we can mutually agree on a mutually beneficial arrangement to move some of these forward. And I think that that's where we need some help, whether that's via legislation or something else. Or whoever the new ASTP czar is now that TEFCA trumpeter Mickey Tripathi is no longer in that office. But I think we need something to spur that. 0057 is one particular use case. We have a lot of clearinghouses. We have a lot of other options for exchange with payers, including direct Excel spreadsheets, which we want to get away from. And what is that stick or carrot that'll get us there?
Thanks so much. Samira, closing thoughts.
I always feel like I just want to say ditto when other people have already shared enough, because all those points were really good. But I will reiterate that I think that the trust component here is extremely important, right? From a technology perspective, especially when we think about FHIR and APIs in general. A lot of that you can Google, as Dr. Rucker said, there, or watch YouTube videos, or look at all the implementation guides or the reference implementation. Like there's so much in the market where you can learn if you want to, right? But the piece that's missing is that carrot or the stick. And for a lot of us, we're at the carrot point. We want to build relationships. We want partnerships to work. We want to find mutually beneficial components so that we can move forward. But that's the biggest struggle, right? How do you incentivize both parties to invest in technology that will support this, to invest in teams that can grow this, or to have vendor contracts to help you along the way? And that's a big TBD right now, but my big hope, and as Marchant mentioned earlier, I might be a little bit more optimistic than him, but my optimism in this space is if we keep having these conversations, we keep bringing the people to the table, we will make a difference, right? We just have to have that one break where we say, here's how we did it from this provider, payer, vendor perspective, and here's how you emulate that. Here's why it's going to be so much easier for you. Here's how we scale. And as everything with healthcare and interoperability in general moves slow, but we will get there. So I will be eternally hopeful and optimistic because at the end of the day, it will work out.
And you're much younger.
So lovely. I feel warm inside, even though it's like 20 degrees in Chicago. Anna, go ahead.
Thanks, Heather. And thank you for moderating this fun panel. This has been a lot of fun. I want to say, Samantha, AHIP has been a absolute fabulous partner in all of this. I know we've gotten to speak at some of your events, and I know, I think this year it's in Seattle. So it'll be real close to us if we want to do something fun up there. That might be a possibility of the future. I think these kind of partnerships are so important to continue to have, reiterating what Samantha says. It's all about the partnership, and we got to bring all the brains to the table so we get to the best answer. And they're not easy conversations. They're hard. In fact, they're business models that are changing. There's revenues that are changing, and it's very hard conversation. And I try to keep that true north of that. This is for our patients, this is for our communities. This is what we're trying to deliver. And yes, we as people who are being paid by these companies to work for them and build these things and build up this capability have to put food on our tables too. So we're thinking about that whole equation for everyone, but we can't see all the lenses if you aren't at the table. So I highly encourage you to get involved with these accelerators that are in the marketplace, talking about what the standard should be, get involved with the policy and advocacy, reach out to your conglomerate groups like AHA and AMA and AHIP. They're the ones who are going to help. Your voice will drive what their priorities are. So we need more provider voices at the table. And if you're out there, please speak up, because we need to hear what you have to say. It's important.
First of all, I total echo that point, Anna. Getting providers to participate is a challenge because they're taking care of patients, but really encourage providers to get involved in these conversations. It's really important. And speaking of provider voices, Terry Cunningham is going to wrap us up with that perfect last thought. Go ahead, Terry.
No, I'm going to say a lot of the things that we've already heard. I mean, I think essential is to kind of the relationships and the partnerships are essential to really any of this work getting done. Obviously, that is got to be founded on a lot of the trust that we've discussed throughout this call. The other thing I think is the belief in the potential of this to really move the needle. And so I think what's important is really to not just learn from some of the experiences of groups like Multicare piloting, the prior auth API and other groups that are piloting and kind of trying to incorporate this at the early stages. I think both learning from what they've done, as well as being able to kind of use that as a way of promoting why this is such a big deal and why providers need to be at the table and why they need to be ready and incorporate this into kind of their IT strategy, et cetera. I think relying on that, which should get more people to the table and get more interest in it, and then hopefully, again, being able to kind of cumulatively realize a lot of the potential of these transactions.
Great. Thank you so much. Thank you so much to all of my panelists on the screen here in front of me. Really appreciate the great discussion. It was, I think, really helpful and a very active chat. Encourage panelists, you have time to go back in and engage with the chat. And with that, I will hand the baton back to Michael McNutt with a fabulous radio voice to move on to the next panel. Thanks.
Thank you, Heather. Appreciate that. We are now moving, and thank you once again to our fantastic panelists. That was a great conversation. I know we had a great planning call that could have easily been recorded and made into the conversation. Our next session is the Patient Access API. It's my pleasure to welcome Leslie Berkeheiser with Direct Trust. Leslie is also co-host of WEDI's co-chair of WEDI's Privacy and Security Workgroup, and she will introduce our next panel.
And good afternoon to everybody on the East Coast, and good morning to those of us on the West. I'm just putting on my camera here. Apologize, just one moment. It's wonderful to see all you today. Well, I'm going to go ahead and get started, and I'll work with my camera and my issues after we get moving on this morning. We did have a full panel planned to turn this whole conversation to the Patient Access API. We're going to be talking about strategies and tactics that we can employ to see greater success. And I just would like to, first of all, be thankful for those of you who are going to participate with this. We've got Dr. Don Rucker from One Up Health, who is agreed to come back to this discussion. We have Tom McMillan from Emblem Health, and I also have Mark Roberts from Karen Alliance. So we're thrilled to have all of you today. Thank you for joining us. I have to say, though, just before we get going, as Michael said, I'm one of the co-chairs for Privacy and Security Work Group for WEDI. And obviously, also as an assessor with Direct Trust, I get to work with a lot of different types of organizations across this healthcare data exchange space. Small startups, complex, those with deep roots, those with lots of technology. And obviously, like all the rest of us on this call, we're interested in making sure this technology gets implemented and the right people get the right data at the right time. That same sentence always works in our business. However, as a patient, I am still experiencing times where I go to the doctor's office and they try to make me sign that I received a notice of privacy practices where I can't see the statement anywhere. I still have a portal for my specialty that's different from my portal for my GP, that's different from my portal for my insurer. And one of the things that just really keeps me up at night is how in the world I can travel and I can download an app if my plane is delayed and I want to be able to get a hotel room at the last minute. And I can get my hotel room by downloading the app on my phone in 2 seconds. And I can't get my data in one place to move efficiently, securely. So obviously, this is home for me. And I just wanted to start with that to say, I think getting the patient to learn how we can trust in the environment and the process is going to be key to all this as well. I'd like to go ahead first, if you don't mind. And Tom, start with you at Emblem Health. Excuse me. I know that I'd like to hear what your current status is on the patient access API. How many patients do you have? They're being engaged in this way. Are they receiving value? What's your feedback? Please go ahead and just jump in.
Yeah. So first off, thanks for having me. I hope everybody can hear me. Before I jump right into that, just 30 seconds just to level set a little context about Emblem Health. So we're an interesting organization. We're both a health insurer in the state of New York. Our primary business is covering all of the municipal and city employees of New York. And we also have an arm of our business, which is a provider organization. We have about 350 physicians and a multi-specialty practice spread across the 5 boroughs of New York and Long Island and some of the adjacent counties. So we're looking at the patient access and patient records problem from both a payer and a provider perspective simultaneously, which I think is a little bit unique for us. And we do that, through multiple different technologies, because as you sort of alluded to in your open, payers and providers are not always on the exact same technology. So as somebody who is one of both of those at the same time, we have different technology stacks for our payer and provider business. But now we have the standards, right, through the interoperability world that have given us lead to an API. And so, again, my contextual background on this, is this is not, I guess, a new problem. And we've been trying a whole bunch of different solutions. I remember wandering around conference floors in the 2020 timeframe, right? 2000 timeframe with personal health records, right? And the interoperability standards of a personal health record was the human. You used to take your stuff and you used to key it into your Google PHR or your, whatever PHR that you had. And that was the only interoperability, was the human actually moving their data around and storing it in this one location. So what we've done is taken the central location away and sort of said, but now there's these APIs that should talk to each other. So after that long-winded intro, I mean, the way to get to your question. So on a parent side, we use a technology called TriZetto's interconnected platform. It's a SaaS software that sits next to our core claims platform. So the payer patient access data is typically claims and authorizations and eligibility and things of that nature. That is a very nascent adoption. So we sponsor about 2 million medically covered lives and another 500,000 dental lives in our insurance business across New York. And I would say the uptake of the patient access API across that 2.5 million members to grab payer data, so paid claims, authorizations, referrals, things that link up to a personal or electronic health record in our provider side, it is very, very low, to be honest, right now. And I believe a good piece of that is it is largely self-directed, and I believe that most patients or insured members tend to not think about the ability to get access to all their paid claims and referrals and authorizations and such as one of their rights. And I think the education is the biggest hurdle. So we've probably got less than 5,000, direct API users at this time on the payer side. Flip that coin over and think about our provider business. We're an Epic shop. So we use the full Epic EMR suite. We have, I'm proud to say, one of the top 10 nationwide adoption rates for Epic's MyChart app. So we've got a little over 76% of our patients as active users on the MyChart app. And the interconnectivity and the patient API access is much higher on the provider side. I think, Leslie, because of your point, people tend to immediately think about bringing a copy of my chart with me when I go from the GP to a specialist, or I need to bring a copy of that imaging report on my sprained ankle back to my everyday doctor so that they can do the follow-up that I'm supposed to do. So I think the education barrier is a little bit lower on the provider side. And out of the, I'll say roughly 200,000 odd members that or patients that our provider practice sees, again, we've got 75% using MyChart. MyChart, again, has that nascent integrated ability to bring forward your medical records and share them, certainly with other Epic practices immediately. And then those folks can access the APIs. So I'll pause there.
Awesome. Thank you. Just a quick update as well. I see that Anna Hyde has joined us from the Arthritis Foundation. Hi, Anna. And as well, I believe Janice is going to come over and talk with us too. I think what I'll do next, though, is go to Don Rucker at One Up Health, please. Can you talk to us about your thoughts, considerations, challenges, ways we can help our patients better understand what it is we're trying to do?
Yeah, I think that on the payer patient access API, the real challenge is basically for payers to get more active in the whole app world. I think that is, to my mind, the challenge here, because they control that. They know who the patients are. They can incent the patients. Obviously, the Epic shops have, tried to capture all of the care and prevent patients from shopping for care. That's the ultimate economic driver. I know they wouldn't say that, but that is the economic driver and the business model. But payers need, I think, a competing business model, which is to provide apps, direct patients to apps, and incent patients to shop, right? And some of that will ultimately need to be a shared savings. Right now, most patients have zero incentive to shop for care, as it turns out, because of the history of our payment system. The country is going bankrupt. Healthcare, from healthcare is costing way too much. I think you're going to see over the next couple of years, one way or the other, that some of those incentives are going to change. And I think as soon as they change and incent more patients to shop, then all of a sudden, we'll be looking back at this conversation with historical interest. Payers are really in a position, though, they're going to absorb that risk more short. So that's a little bit longer term, obviously, right? Because that requires, a couple policy changes that we don't have line of sight on in the current Congress, or frankly, the new administration. What we do have line of sight on are Medicare Advantage star ratings. And, Congress has said that Medicare Advantage, so the MedPAC report from July of last year said that Medicare Advantage is 22% overpaid. Think about that. That's a vast amount of money for folks who follow the Medicare Advantage series of reporting stories in the Wall Street Journal, where the journal has identified that we as taxpayers paid MA plans over $50 billion for diagnoses that were never treated. Push is going to come to shove here, whether it comes through directly through star ratings or modification of star ratings. But somewhere it will come in the Medicare Advantage payment world where those patients are going to be incented to get more digital. And I think that will be a watershed moment. And of course, it's that more digital is not just here's your medical record, here's, how the doctor treated you, but it's going to be rich on things like prevention and lifestyle and chronic disease. It is not going to be anchored on, you had, your doctor's visit 6 months ago or every 6 months, right? That's not really the way to treat hypertension when you get right down to it, or type 2 diabetes or any of these chronic illnesses. So I think that conjunction of incentives is what ultimately is needed. The APIs are just the first tool for some of the early apps, primary, there are a number of EHR apps that people have out there, but that's what I think is going to happen.
Thank you. Thank you for that insight. I'm going to come back to your point about patients are going to be incentivized to shop. I'm going to pick back up on that a little bit later. So I'm putting a pin in it. I'm going to go next to Mark at Caring Alliance, and then Anna will come over to you. So Mark, at Caring Alliance, we've been talking all day about how we've got regulations to provide this push to move towards this data moving around via these endpoints. We've got standards to enable interoperability. But obviously, significant change is difficult in our environment. What are you thinking are some of the missing ingredients from your perspective, from Care Alliance's perspective?
Yeah, thank you for having me. Care Alliance, just as a quick plug, is a multi-sector healthcare alliance, also HL7 Fire Accelerator, committed to enabling consumers and their authorized caregivers to get, use, and share the digital insurance when, where, and how they want to achieve their goals. And I think you're right. I was nodding my head when Tom was speaking earlier about a number of his points. I think, one of the biggest challenges here is we have regulations now. We finally have some sticks that are moving folks in a direction where interoperability is actually possible, and yet it is. I mean, just from a personal standpoint, I've been seeing it. We were a long ways away from that. I mean, I was with my daughter who isn't covered by this all, but I was still able to get her her data on my iPhone, and I was able to screen share her test results when we were in the ER with a doctor who could at least read the results and actually could see something. They still had to run their own results, but at least it was a step in the right direction, right? And that was great. I mean, obviously she's not covered by these rules because she's a child, but still, I thought, hey, we're heading in the right direction at least. But I think there's a lot still to be done. We're doing some work with a digital insurance card. It's still in the early phases of folks implementing it, but the first use case of that is just the simple check-in, right? It's getting rid of the physical insurance card, mapping the data elements to Fire, and you can now use, just like when you check in, I think you mentioned kind of at the beginning, you check in for your flight with your phone. Now you can check in with your phone for the doctor's office. But once folks start implementing that, it really opens up the capabilities and possibilities, because a smart health link on the back end is really just, for lack of a better word, a website. You can add anything you want. It's up to the payer to decide how they want to handle that. It's encrypted on their end. There's oftentimes a PIN or some other device mechanism to secure that data. But you could add all kinds of information to that. You could add your questionnaire information. You could add labs to that. You could add all kinds of stuff that you could carry with you on your phone, with you wherever you go. And as long as you have some kind of a reader, that information could flow with you as one mechanism. We're also working on doing a potential real-time pharmacy benefit check use case as well. So you could also get your cash price or your price with using your insurance on your phone as well. So there's stuff in the works, in the pipeline, I suppose, but it's sort of like what we've been discussing now for a number of years. We're working towards the end goal of having all of these great capabilities, and yet we're still seeing roadblocks and barriers constantly. I think a lot of our members who are app developers are struggling to get they're having issues with refresh tokens. They're having issues with getting access to some of the information. They're getting kicked off once they do have access to it. And I think Tom made a really great point on folks not even being knowledgeable that this is even available to them. I've often thought, wouldn't it be amazing if folks, different payers out there had these great advertisements or splash screens or something that advertises. They're spending all this money on implementing this. Why don't they tell the patients this is available to them, right? So I think as we move forward, that'll become more common, more used as well. But I think we've been doing this for a long time, but it still feels like we're still in the infancy in many ways. And I do think we'll see some changes. We're definitely seeing steps in the right direction, but there's a lot of work to be done still, for sure.
Awesome. Great key points there. Anna, I'm going to go to you next at the Arthritis Foundation. Obviously, your organization represents a substantial and influential constituency. Are you getting feedback similar to what I started with today with, hey, I'm really kind of backwoods here, getting all different kinds of portals. I can't get my data together. I'd like this to be more like the travel industry or other places. What are your members telling you?
Yeah, 100%. I agree with so much of what has been said already. 100%. I think when we first started really talking to patients about what could make their care easier, the management of their care, not their actual care, it all relates back to that. They would call it a one-stop shop, like a FedEx tracker, right? Like I know exactly where a PA is in the process or whatever it may be, so that I'm not the one having to triangulate all the time. So conceptually, that's kind of where patients are. And I think it's important to make a distinction too between a chronic disease patient, someone who is a high utilizer, consistent utilizer of care versus a passive sort of consumer of care, such as myself. Because I went back and actually read some of the comments that I had flagged from the CMS rule around, for example, prior auth and whether patients even need to know. Patients aren't sophisticated enough to know and won't understand the data elements. And I could not disagree more with that. For better or worse, patients in my therapeutic area, arthritis, know all too much about the PA process, and they know all the acronyms that we use because they have no choice. They know ICDs and NCDs and all the things, EOBs. And so I think that's an important distinction going forward. I also believe, like what Tom said, that the education is one of the biggest barriers here, because you don't know what you don't know. I mean, patients, if you were to say patient access API, and I have done this exercise with several of our kind of patient focus groups in the past, they don't know what that is, because why would they? Nobody's talked to them about it. Even if you put information out about it, like, hey, there's this new opportunity that you may have access to, they're going to probably conflate that with either their health payer specific app or their provider's specific portal, and even across that, they complain, I have, 5 or 6 different providers that I rely on just to manage my arthritis. They all have different portals. So I got to keep up with all these logins and that same kind of quarterbacking around. My rheumatologist doesn't have the lab from this other, and they're asking me, well, why would your other provider say this? Well, why don't you ask him or her? And so having that kind of place where everything can be centrally located, certainly a game changer. And my last point for the moment is just to kind of put a fine point on it. Before, in preparation for this, I actually went on to my own payer, who I will not name, portal, and just asked in the chat, what can you tell me about patient access APIs? And the bot, or whoever it was, someone supposedly named Karen, on the other end wrote back in the chat, let me route you to our privacy department. So I couldn't even get information from my payer about what a patient access API is. Granted, I am not, on Medicare. I am not, I don't have an ACA plan. But nonetheless, I thought asking a broad question might generate at least some information that would kind of guide me in the right direction. And instead I got nothing.
Yeah, and I know, just to come behind And I would actually say that what we haven't really done is taken a lot of what I think people don't know exists or take for granted today and pushed it forward into the patient as their own advocate's view. You know, as the panel spoke, you know, every provider can get real-time eligibility, whether it's medical, pharmacy, dental, eye vision in real time from the front desk of the doctor's office. That happens today through ANSI standards that have been in place for 25 years. You know, my organization, we've now over the last 2 years been putting technology in place where about 54% of our authorizations are purely digital and actually approved in real time, where the provider's office gets an authorization number sub 1 minute, right? So a lot of these standards for integration exist, whether it's through ANSI standards, just general straight business portals that provider organizations and revenue cycle and clinical organizations have been using for the better part of 10 years. What we really have failed to do is create a compelling use case for the patient in the middle to become their best advocate, right? One of the things that we believe is going to be a big driver, and this took flight maybe 10 years ago, but kind of fizzled, you know, value-based insurance design, right? And insured members who get premium reductions when they have evidence of having completed clinical and care management, disease management activities. You know, some of the other APIs that are called for in the interoperability rules, there's the payer to payer, where through consent, a member can consent a new payer to go grab their claims and their information from an old payer. Well, that's great for the payer. It gives us the ability to look at risk adjustment. It gives us the ability to look at continuity of care. It gives us the ability to look at providers. But if the patient knew that grabbing those claims data could easily allow them to grab insurance-based design premium reductions, now you've got a compelling self-directed care. They're going to want to go find out about that API because it might save them $50 a month on their insurance premium. As Don said, they're now shopping. They're using the data to shop their own benefit, right? They're using the information to perhaps, you know, say, hey, if I have this information, I can get care in a more easy way. I've got a standing authorization from my last healthcare coverage, or I can walk around knowing I have 30 PT visits on my benefit. I don't have to wait at the desk for them to talk me through 25 minutes, as Anna said, of what's an authorization code and all that stuff. They become advocates because it simplifies access to healthcare. You know, when we talk about education and we talk about wellness, you know, one of the business units that we have is also a digital wellness business with group and individualized coaching and rewards programs and social competitive kind of programs and that kind of stuff, all for the purpose of care. We're finding a lot of uptake into those programs, self-directed uptake from patients and insured, because they know what the value proposition is. I think we need to educate on the value proposition to the individual patient of being the center of their healthcare information, whether it's provider API, right, or patient API. They're seeing claims and lab results and prescriptions and everything else, right? And you'll get into the same types of shared incentives that Don talked about, where, you know, a new member, if they upload all of their open prescriptions, and as an insurance company, we can get them onto mail order 90-day refills. That's a value proposition for everybody.
Right.
Simplifies care, doorstep delivery. Amazon will drop it off along with your paper plates or whatever you ordered. I mean, there's a lot out there that I think if we could create the awareness of these member and patient value propositions, that we'd see an uptake and a desire for the private free market to start to come in and help us do that education journey. Just the same as when Apple launched the iStore 15 years ago, there weren't but a couple of apps on it, but now there's millions. Well, why? Because there was a economic opportunity for every application developer to go put their app out there to tell us as the consumers what it was for and why it's helpful to us.
Right.
And I think that's what we need.
All excellent points. I want to ask for Karen, Janice Karen, who's going to be jumping in a little bit for us too, to say some comments first, and then we're going to come back and tie everybody's comments back up with another discussion. And we are going to run 5 minutes over on this one for everybody who's watching the clock. Karen, Janice, Janice Karen.
Hi, no worries. Most of you probably know me, but I'm Janice Karen from the Massachusetts Health Data Consortium, also known as MHDC. And among other things, I lead our data governance collaborative, which brings payers and providers together to talk about data quality, data standards, legislation related topics, and just part of the reason why I'm talking about this is that I've had a lot of conversations both in our data governance collaborative with the payers and providers there, with app developers, about how the first round of patient access API went. And, you know, as some of you who've been reading comments today see, you know, the marketing and the knowledge of things being available is definitely a point. But what we found to be the bigger issue was that for many payers, there's this sense of, well, if we build it, they will come. And when you talk to the app developers, you know, that's just not the case, because they're not treating the API as a full product, by which I mean, as someone who's worked on APIs that are products, they're not providing documentation, they're making a very onerous and difficult to understand registration process. You know, that got mentioned briefly earlier. They're not explaining the decisions they make around implementation that go beyond the sort of general requirements of the implementation guide. They don't have useful sandboxes or test support. They don't have useful customer support and all kinds of other pieces like that. And those are some of the things that have really been missing in this process. So I know I've had conversations with quite a few app developers who want to implement the patient access API among a much broader swath of payers, and they just hit a brick wall on the actual implementation side. When in some cases, there's also the endpoint discovery, which we talked about ad nauseum earlier as well. But there's just a lot of things that go beyond. This is, you know, we've stood up the API, and that should be sufficient in order to make something actually useful to people who want to use it. You know, I also want to comment on the marketing point that people were making earlier. It's one thing to tell patients about something, even that it'll let you use your apps, but what's really needed is for a wider swath of developers to know that it's available, and how to get to it, and how to use it, and how to find the other support things that I was talking about. So I think that's a really important piece of the conversation that doesn't get mentioned often enough. It's not enough to have just an API. You actually have to have all the pieces around it to make it a usable product by someone who wants to code against it.
Right, right. I'm going to take what everybody said and kind of turn it around into a question and throw it back to all of you. So I started by throwing out my example of I'm on a plane, I just got delayed, I grab my app and find a hotel room for the night. I happen to be a Marriott member for years, so I would just use my Marriott app. What am I going to do as the patient? Is it the doctor that's going to say use this app? Is it my insurer who's going to say use the app? What's it going to look like? How do I know I can trust it? How do I know it's easy to use? Where is it going to come from? That's the part that I just can't see transpiring. What are you all thinking? Anna, I'm going to go backwards. I'll go to Anna, then Janice, then Mark, and Tom and Don. So Anna, you go first, please.
Sure. Well, I have the same question: is where is the onus for educating the patient? And I think probably it should be a little piece of everyone, including me as the patient kind of advocacy organization who consider ourselves kind of a trusted entity for patients to come for guidance and advice. My reach is only as big as it is, though, and that's where I think the payer community, of course, and the provider community play a big role. You know, there are obviously kind of nuances and complexities within that. You know, you have different providers; they may not even be all in the same network, or whatever it is. So there are some things like that that make it tricky. But I think it needs to be an all hands on deck approach. And I think that other pieces that are really important, because I've seen some things in the chat about the privacy and security. I totally agree with one of the comments that I don't know how comfortable I would feel signing up for one. It's just, you know, at any time you see something that feels new, even if it's just new to you and it's not really new in the world, there's an inherent kind of distrust. We see that with our patient population all the time. We've asked questions about AI and that sort of thing. And it's like, you know, you need to kind of see, you need to be able to kind of experience it and build the trust. It doesn't come inherently. And, you know, I think patients, when it comes to privacy and security, they feel, you know, comfortable sharing their data to an extent, but they want to know how it's used. That's something that we've heard over and over again. And I think that's a legitimate question, considering that there are different regulatory standards, whether you're kind of an entity regulated under HIPAA or not. And a lot of third-party apps are not. And so I think that has raised a lot of alarm bells, some that have become mainstream, and our patients are seeing those things. And so I think that's something that really needs to be contended with as well from an education and trust building standpoint.
Yeah, definitely. That's something I hear all the time, of course, being in the accreditation certification space, that being able to prove to others that you can be trusted as an app developer, for example, if you're not subject to HIPAA and have no other way to prove that your data can be exchanged. Janice, let's go to you next. Thoughts about that with respect to what it looks like?
Yeah, well, I would just comment that privacy is an issue in all those other areas too, and HIPAA is not there. The FTC has a fair bit of oversight, and I think that there's a tendency of people in healthcare to sort of freak out about privacy if it's not under HIPAA, because they equate HIPAA and privacy, or HIPAA and security, as if they're equivalent, but they're not. And there are lots of ways that you can be sufficiently secure and sufficiently maintain privacy that don't require HIPAA. So I'll just put that out there to sort of put a something on that conversation. I would just suggest that as an industry, there is a need to think about this is something that we want to do to be able to interact with the modern world and what people expect from the modern world. And I'm not suggesting there's a lot of we can't, we never, we haven't, we shouldn't. And I'm not suggesting that, and some of that's valid. And there's always fear of changing and doing things differently. But, I would suggest that once you have that initial reaction, that you think about what it is that you're trying to solve and whether it can be solved in a different way. If it's security that you're particularly worried about, are there things that aren't HIPAA that are sufficient and successful, and can you apply them? If it's patient consent that you're worried about, how does that work in other areas that are sensitive? If it's making sure that apps are usable and people have the right to pick what they want for an app, how is that done in other industries, and how do we incorporate that? So I would suggest that even though it's very natural to sort of go back to what you know and what you think about and have this view of the world of how your world has been for a very long time, and sort of have some fear of making changes to that it's imperative right now that we all think about that, think about what can be changed, what should be changed, what shouldn't be changed. I'm not suggesting that everything has to get blown over with the wind, and what we can do to do this in a way that's not going to break everything, but that will still move us forward to where people expect us to be going, and to allow us to improve patient care, outcomes, quality, financial systems, price transparency, trust, all of the things that we're all working on right now. So I guess I'll kind of wrap it up that way.
Excellent. Mark, let's go to you.
So about, I think it was almost 10 years ago now, one of the very first projects the Carolinas worked on was a code of conduct, which provides a set of guidelines for how covered entities not covered by HIPAA, such as third-party apps, as we were just discussing, can voluntarily handle healthcare data on behalf of the consumer. The code is based on a central theme that third-party apps need to ensure that consumers or their authorized caregiver provide informed, proactive consent for how that healthcare data is collected, used, and shared, giving consumers complete access to and control over their health data for entities not covered by HIPAA. And we just I think we're working on our most recent version of that. I can post in chat here a link to that code of conduct. I know One Up Health, Don Rucker's, the organization he works with, is a member. We have 40 apps signed up there. It's a voluntary, totally free voluntary process. There's the code of conduct is on the website there. You can take a look at it. And it really does kind of walk through all the different, it addresses a lot of the concerns I think a lot of consumers have about what happens to your data, or what can happen to your data. There's a lot of nefarious things that happen to folks' data all the time when they download things on the Apple or Google or other app store. They may or may not be aware of it because they click through it. But we felt it was really important that consumers be aware of that. And it's also something that I know a number of other payers and others are in the industry are really concerned about as well. And have been involved with helping to develop this code of conduct. So that is not saying it's a silver bullet, and but it is an option, and it is something that that we've been working on for a while now. And as I mentioned, we're in our second iteration, I think, on this now, and I think for apps that are working on that, it's clear that they are also really bought into this concept that consumers really should be aware of what is happening with that data, and it is their data as well. I think that's the other important piece for everyone to remember.
Mm-hmm. Dr. Rucker?
Yeah, I think so the privacy stuff we obviously wrestled with the Cures Act rule. It was used as one of the things to try to prevent patients getting access to their data. I would point out in the app world, I think there's sort of two broad sets of protection. One is legal. So if apps, they're required basically through the API sign-on, so the EHR can give a warning that that your data is moving. That was something that we negotiated with the EHR vendors. So there is that warning, bright red type of warning. That is actually enforced by the Federal Trade Commission as deceptive and unfair business practices. So that is actually illegal to do. You can ask Mark Zuckerberg, who paid $5 billion for violating those principles, and the next time he violates them, he'll spend some time behind bars. And I'm guessing, reaching out to a friend may or may not help. I guess we're giving out pardons pretty willy-nilly these days. So, but it is a crime. I think the other thing, Leslie, to your point, is apps earn trust by providing value. The reason you've given up all the privacy of your entire travel to your airline or your hotel or your bank or your brokerage firm is because they add value. And so I think a lot of app trust is really how do we enable apps to add value in a competitive healthcare market. And that's obviously a broader how do we pay for healthcare question.
Mm-hmm. Thank you. Tom?
Yeah, so Dr. Rucker stole a little bit of my thunder, because what I was going to do is say I would actually change your airline analogy to a banking one. Your airline lets you look for another flight on their airline only. Your banking app maybe lets you see what kind of money you have in 4 or 5 different accounts. Your Bank of America can link to your Charles Schwab account or to your TD Bank account. You can there are APIs today that let you establish recurring monthly payments out of one account by setting that up, and you trust it. And I think Dr. Rucker also made a very great point that I was going to make, which is people will trade trust for convenience at an astounding rate. Mr. Zuckerberg and Facebook have atrocious privacy policies. People don't care because they're more interested in looking at the content. They'll sacrifice the trust and the truth behind the poor policies because it gets them something they want. And so I'll use the banking example again. We like having a Bank of America app that lets us tap our phone now to pay. We like having a Bank of America centralized API interconnected with other banks so that I can walk up to a TD Bank ATM and pull money out of my Bank of America account, and they talk to each other. I've never trusted or had a trust issue with my balance at another bank's ATM because the standards allow for that to be managed correctly. And I think what we would find is that there's a value prop to the end user, in this case, the patient or the insured member, that allows them to move about society and have access to their patient records in a way that simplifies or adds some value to their seeking of care. So said differently, if we start to look at insurers or your primary care person, who, whatever that physician or entity or health system, if your primary care doc in New York here is at NYU, but NYU's app lets you find the most available appointment at New York Presbyterian, you might not really peel away from NYU, but they're providing extra value for you and saying, hey, we can't get you today, but NYP can get you today. And now you're more likely to stick at home with one provider. So I think part of you asked the question, Leslie, like, well, what will this look like? I think it's going to look more like other, I'll call them industry segments that we as consumers take today. We look at banking in the way that I just described, or you look at travel, maybe you go to Orbitz and Orbitz tells you that here are all the flights. And if you have a leg that has one Delta and one American, they stitch it all together, right? So I think when we find somebody who steps forward, leveraging the patient API standards or the provider API standards or the payer-to-payer API standards, we have a consent engine on our tool. Members do consent to who we are allowed to share and who they give access to source their records via the patient access API. Consent, FTC trade protections, and quite frankly, just the public promise, meaning we won't readily screw up and lose your data, and we'll give you some significant convenience or transparency in how you get care, how you pay for care, the quality of that care. Once we find a way to hit all those bases, I think we'll have that home run. Right now, what we have is a set of standards and a set of players, but we haven't really figured out the rules of how they all work together with the patient kind of sitting in the middle. And so I think that's the challenge the industry still has to get through. But, at least now, again, we have some federally mandated standards that should speed the plow a little bit.
Right. Well, thank you so much. Before I thank this awesome team, I really appreciate it, especially those of you who even jumped in to help at the last minute. I do have to put you to work very quickly. I'm going to ask all of you for one more contribution, please, as we get ready to close on this panel discussion. And that is on the Privacy Security Workgroup team. We've known for a long time. We've been wanting to help somehow explain to patients how they can trust this process. And obviously we're early in the whole thing, but it's clear to me today that value proposition and being able to explain that to all stakeholders is what's going to get us there. So one word, what is your key value proposition that you think the patient API is going to bring the patients, or perhaps all of us? I'm going to ask each of you as we close. Tom, since you ended, I'll start with you.
Convenience.
Okay, awesome. Dr. Rucker?
Yeah, I'll double down on convenience and categorize it with anchored by public key modern cryptography. So you know exactly what's going on.
Got it. Mark?
My hope is for usability, accessibility.
Usability and accessibility. Awesome. Anna?
Yeah, I think convenience too. I think that value proposition is really critical.
Yeah. And Janice?
I will say eventually control over your own data.
Control over data. Awesome. This helps us a lot in stepping forward. As one of our goals is to help our industry to implement, we really need to push that trust and transparency on the patient side as well. So big thank you to everyone who's contributed today. We greatly appreciate your time and expertise. Michael, back to you.
Leslie, panelists, thank you so much. A fantastic panel. Our final panel is up, the role of intermediaries. It's my pleasure to introduce the moderator, Patrick Murda with Centene.
Thank you, Michael. And we have got quite a powerhouse panel. Michael, can you confirm in my video? Yeah, there it is. Couldn't see myself there for a second. We've got quite a powerhouse panel to finish out the day here, folks. So we're going to get right into it in just a second. Before we jump into it, I do want to give our panel a quick chance to introduce himself. This is quite a distinguished panel, so if we could keep it brief, otherwise it will take 2 hours to get through the credentials of this team. So I'm going to kick it off. Patrick Murda, I'm the IT VP of Clinical Product and Architecture at Centene Corporation, and I'm also an industry ambassador for interoperability. I'll go to Dr. Don Rucker.
Yeah, Don Rucker, Chief Strategy Officer, 1UP. And Patrick, thanks for all of your help on interoperability, including FAST, and congratulations on the new gig.
Thank you, sir. Nancy Bevan.
Nancy Bevan, Director of Interoperability Strategy for Medica, and Industry SME for Payer Interoperability on several different groups.
Among many other things. Bob Oakley.
I'm Bob Oakley. I'm the Strategy Interoperability Lead for the Physician Innovation Team at Evernorth and working to enable exchange across the industry.
And Sherry.
I'm Sherry Wilson, Executive Vice President, Chapari Solutions. Been involved in lead and interoperability with the clearinghouse and a member of the cooperative exchange, very actively involved in how we can get engaged more in this initiative.
And Beth.
Good afternoon. My name is Beth Davis. I'm with Veradigm PayerPath. We are a clearinghouse. I'm representing the cooperative exchange along with Sherry today. So thanks for having us.
And Brian.
Thank you, Patrick. Brian Weichel. I'm the Director of Account Management nationally for Velatura and Velatura Services. Thank you. Appreciate it.
Great. All right, well, let's jump in. So I'm going to give you a bit of historical context to set the stage. And I'm going to start out by saying intermediaries have been on my mind for 20 years, going back to the initial HIP implementation back in the early days, right? And one of the dynamics that I've seen over the last many years as FHIR has become more and more part of the infrastructure is that there's almost two different mindsets, right? We've got folks that see FHIR from an academic perspective, and you've got endpoints that should only talk to other endpoints. And then you've got a group of folks that are more familiar with established models such as EDI, version 2, version 3 of HL7. And sometimes those folks talk past each other. You've got the purist from an API perspective and those that have fought some of the healthcare battles going back many, many years. And I think, as we get into the discussion here, been in the healthcare ecosystem for a while, recognized that this truly is a hybrid environment, right? It's not theoretical, and by definitions, and it's a hybrid model. And recognizing that in a complex organism like we have in healthcare, let's talk through the values that intermediaries provide from a security, scaling perspective, and that type of thing. And before I even get into that, or before we get into that, I do recall conversations going back a couple of years and even getting to the definition of what an intermediary is in this space was a point of contention. I see Nancy smiling because she was on many of those calls in the sense that I remember, Dr. Rucker, you mentioned the FHIR Scale Task Force, where some of the early meetings, it took us a while to get to the fact that when we're talking about intermediaries here, we're not just talking about under the cover software that's doing, communication between two endpoints. In this case, we're really talking about organizations that may be using some of that software, but are providing business, operational, scaling capabilities, abstraction layers. These are actually business capabilities, not just a little piece of software, because it took a while to get folks from the API-only side of the world to understand that intermediaries in this case are a little bit different. So with that being said, let's go ahead and kick it off. First of all, I'm going to start with you, Dr. Rucker. Would you like to elaborate on anything I described there as it relates to the definition of an intermediary in this case? And once you get past that, feel free to jump into what you think the roles of an intermediary are in the brave new world of what we're dealing with.
Yeah, Patrick, you mentioned a number of great things there. And, I think if you look at intermediaries in general, in the modern world, right, we are sort of trying with things like TEFCA and healthcare in general. We try to reinvent as opposed to using what the rest of the economy has. That seems to be like a standard go-to activity for us over the last, my entire career. We have a modern internet. We know what an immense address space that's really skinny and really fast. It's called domain name services and IP addresses. So we don't need to invent kludgy provider directories or this kind of stuff. We know exactly what security is, and it's public key cryptography, right? It's not somebody vetting an exchange purpose in a non-transparent way. We know how to do these things. That's why AOL is not really much of a business anymore, right? The modern internet has just removed all of that intermediary. So I think as we have our discussion today, as you've alluded to, thinking about what the actual value of an intermediary is, rather than its role in maintaining current business structures and preventing modern digital competition needs to be part of that conversation.
Perfect. Thank you, Dr. Rucker. Nancy, let's turn to you. So the what and the why, the role of intermediaries and their importance in healthcare. I know you've been on the payer side, you've been an industry consortium for years. Give us your perspective.
I like to think about intermediaries as bridges. So, and vendors that can help us fill gaps. And I think I talked about this earlier in a session that especially medium-sized payers that don't have the resources to do it all at one time, or to be able to be ready for some of the rules that are coming up in 1/1/27, that being able to focus on what their core competency is, and actually, even if it's not yet a core competency, but the things, the kind of the foundational rocks that have to come from the payer, you've got to have the data, you've got to have, I guess you could have a intermediary for consent, but it just feels to me like consent reporting training, that kind of thing, are kind of key core to a payer. But as you get out to some of the other pieces, even having the fire resources, or building the fire pieces, or building the fire fabric, if you're not ready for that, that's where I think intermediaries play a really important role in helping the industry move to all these new strategies together, when everybody is not at the same place to start.
How about you, Bob?
Yeah, hi Patrick. I would echo a lot of what Nancy just said. My image in my mind is that, there's a transmission system for exchange, right? That not all the data is the way we would necessarily want it to be, or in the format we'd want it to be. There's ideal pockets where we're getting exchange via fire, or via some known known process we've been using for years. But to do it at scale requires somebody that can get in and do that heavy lifting, that hard work, and consolidate the information and present it to us, right? So it's not just providing exchange of data, but there's some heavy lifting going on in helping us, and adding value to the process. That's where I think that's where they become valuable, is when they're more than just a socket set.
Yeah, Bob, and double click on that a little bit more. For example, data aggregation capabilities, scaling capabilities, even for organizations that, like Nancy just said, want to focus on their core competencies and would rather have another organization get data in, get data out. Is that kind of how you see that?
Yeah, exactly. Because it's not, at the end of the day, it's not about what it's not about getting the data. It's using the data for what your intended purpose is. And if you can smooth that out, that becomes a really valuable capability to quite a few organizations.
Yep.
Patrick, hey, sorry to interrupt. I would like to add on to that. This is Beth. So many of us in the administrative world have been here for a really long time, and we have personally participated in growing this network. We've been there through every stage. We continue to be through every stage. So a new standard or fire API, that's not that intimidating to us. We understand that. We understand version control. We understand how to do APIs. We understand batch and real time. We understand all those things. We bring a lot of value. But I think one thing that kind of gets lost in the mix is with clearinghouses, there's a lot of value that we add on top of that. So if you think of a point-to-point transaction, you've got two parties in that. You've got payer, you've got provider, and anything that happens between there, and there's a lot that can happen, that conversation has to happen between those two organizations. If you have a clearinghouse or an intermediary in the middle of there, we smooth all that stuff over. We do your up and your down. We normalize the data. We give you the benefit of what it looks like on this side of the country. We're across the nation. We touch thousands of providers, thousands of payers. We have the history of the growth over time. We know how that works. Applying a new technology is not as hard as that sounds like, as it is bringing those business process over the top of that and normalizing that, giving a streamlined experience. And then that really helps your smaller and your lower one, the smaller providers, but it also helps the larger ones who want to concentrate on giving patient care.
Exactly. It's the capabilities on top of the underlying technology. Yeah.
There really is. We answer those questions that are in between. We clarify and we bring history and nuance and other payer behaviors to the table to describe to the situation.
Brian, what are your thoughts on that?
You know, there's a couple words that were spoken earlier, and bridge, I think, was a good word. I mean, obviously what we do as an intermediary, I think some of the best things we do is obviously in playing a crucial role is bridging that data, right, between, you know, service providers and consumers. But I think one of the words that I don't think is necessarily used a lot, and I don't think it's a dirty word in our ecosystem, and that's ROI. I think we have to look at you know, an ROI, and I know if I put on my hat in the morning, what am I doing, you know, as a company that's providing an ROI for the consumer, right? What am I doing for the payers and the providers that we're working with as well? So I think, you know, there's challenges. There's definitely, you know, in the marketplace with data, you know, incompatibility, there's security risks, there's, you know, there's version changes and everything that we have to stay on top of, and rule changes and those things as well. But I will say that if we meet those challenges and we're able to adapt, then the ROI, depending on which bucket we're playing in, we're talking about efficiencies, increased efficiencies. We're talking about potential net new opportunities for revenue based on the data that we're flowing. But I also circle back in that we're always talking about data, but I also am very concerned that it's good, clean, readable, understandable, usable data, and it's the correct data. I think we always have to keep that in mind as we go through this process.
Yep, no, good points. Sherry, do you want to unpack any more of that?
Sure, I think echoing the same points, and I think really important what we bring besides industry resources and our expertise, but also that economy of scale and faster time to value that we're just talking about. And I think, you know, we are able, through leveraging our existing infrastructure, to be able to reduce those operational complexity and implementation and maintenance costs, but also that time to value is really important. When you go into a boardroom and you're talking to your board about, you know, being able, hey, let's implement this, let's, you know, get behind this. It's like, well, how many people are doing it? How is this working? And again, I think the value we bring is we have this existing infrastructure. We understand the execution of a new EDI standard. We understand that we need a global approach to interoperability to be able to, you know, achieve these economy of scales and sustainability. But that faster time to value, as we talk about the quality of data, is our ability to be able to deploy and connect, you know, new integrated solutions quickly, be able to help drive innovation. And I think that's really important value that we bring to the table as intermediaries.
Yeah, but I would kind of phrase it up as, for a lot of organizations, the ability to abstract from that level of complexity and let the experts handle that while you focus on your business or your clinical shop is key, right? So well said. I think we've kind of hit the nail on the head on that one. So I'm going to do a quick panel poll here, just for my own information. Raise your hand if you remember the 50-10 implementation. Come on, everybody remembers it. Raise your hand right now. All right, cool. So with that being said, what can we learn? What parallels can we learn from 50-10 as it relates to what we're doing with CMS 0057, as it relates to intermediaries, and what can we bring forward? What were some best practices that we got out of the pain of the 50-10 implementation? Some of us still have scars from that, but we got through it and we learned. So what can we bring forward? What some patterns, things that we need to take into account as we get into the brave new world of 0057? So let's start in reverse order. Sherry, what's your perspective on that?
Well, I think we all remember implementing a new standard, the challenges that came with it, and also the variety of stakeholder constraints, you know, operationally and technology. But I see the same challenges that with the implementation of FHIR as we did in implementing HIPAA or the 50-10. And I think our expertise we bring to the table is to be able to leverage that to bridge the infrastructure and to be able to enable this interoperability. We realize that we're going to need to support like a hybrid approach to meet stakeholders where they are. We're going to need to be able to support, you know, HL7 FHIR, X12, to be able to maintain a flexible infrastructure to help, support emerging standards and new technology. So I think it parallels, and I think we're well prepared for over 25 years of experience in the industry to be able to leverage that to achieve quicker access and implementation in the industry.
Gotcha. Let's get a payer perspective. Nancy.
This is a really good question, by the way. I think not trying to boil the ocean, kind of back to what I said before, determining, what do you do well? What do you have the infrastructure to support? And then where should you lean on intermediaries to help you fill in the gaps? And then I think no offense to the intermediaries, but making sure you choose intermediaries that can deliver. I mean, make sure you understand what their capabilities are, how much work they have on their plate. 5010 was huge. They were trying to do a lot of work for a lot of people. So I think it's important that when you identify the places where intermediaries can help you, I really like what Sherry just said, because, we had to be in the world of 4010, 5010 all at the same time. We couldn't just switch from one to the other. And so that was challenging. And I always think about, Patrick and I've had this conversation many times, what can we do today? And what do we have to be ready to do tomorrow? And I always try to think about interoperability that way. I have to lead my organization to say, this is what we can do today. And so we have to be able to participate in maybe an older technology that we don't want to, but we always have to have our sight on what's next. And we have to be prepared and ready and doing that work in parallel to be there. And I think that was a lesson we learned from 5010 too, is making sure that you're always looking at what's now and what's future. Also just using intermediaries where they make the most sense and making sure you choose intermediaries that can meet your expectations.
Well said. Well said. Dr. Rucker?
Yeah, I think you have to start small and sort of advance from there. I think that was frankly the point of the US CDI, and before that, the CCD on the clinical side. Let's not digest the entire medical record. Let's start, in sequence with pieces of the medical record, the CCD back in the day and, the US core data. I think on the 0057, so the payer side, putting the claims data into the fire resource explanation of benefit, right? We're only touching a couple fire resources realistically, in the base implementation of the 0057 access APIs, I think is a great start. And I see that as sort of pre-digested because, as Beth mentioned, that EOB data has gone through a lot of workflow from clearinghouses and providers and payers before it comes into the 0057 slipstream. So I think we leverage all of that cleanup and, get our feet wet with that, and then we can go to the richer things.
Brian.
Yeah, I think you have to look back at what worked and what didn't work, right? And obviously, with potential enrollment issues, missing files, documentation, the fact that you had to go back and look at eligibility issues and things like that. I think companies like Velatura, I think we learn from issues like that, and we adapt and make those changes. And again, I think some of the things that we bring to the marketplace is understanding the challenges of what worked and what didn't work, and then pivoting and kind of to what it's already been mentioned is doing what you do best, right? Is staying in your lane, do what you do best, align yourself with partners that make you better, that fill a gap that you may or may not have in those certain areas, and just provide value at the end of the day. Everybody's kind of, evolving, as it were, and I think we're all learning from as we go forward.
Yeah, and thinking back to some of the experiences that I have, one of the key things that I think intermediaries did for us during that time was almost a buffer, right? So you had 4010, 5010 coming in, and intermediaries were buffering some of the noise before it got to the, quite honestly, the legacy adjudication platforms, which are big and expensive and a lot of investment in, but we're not necessarily ready for that level of noise. So I think that was a key thing. Bob, your thoughts on that?
Yeah, you just hit it. For me, Patrick, is that the takeaway for me from 5010 is that not everybody's going to be in the same place at the same time. And again, that's why I think of the intermediaries as that transmission system, right? That if you can make that exchange between two organizations seamless, and then you're the one in the background cleaning up the data, getting it in the right format so it goes through and loads properly each and every time. That's a tremendous value. It allows for speed to value for the smaller organizations that are investing, taking a much bigger risk as they implement. I think for me that was the biggest eye opener for me with the 5010 implementation was just just how ununiform the implementations were across the market, right? That there was a need to smooth it all out.
Yeah. Beth, your thoughts?
Yeah, so I think one of the things that I'd like to point out is that, when we went to 5010, we were already at scale with 4010, right? So it was a version change. So we weren't reinventing a network, we were upgrading it. So clearinghouses and intermediates absorbed a lot of the support for that change. So not only were we physically up converting, down converting, determining who takes what, and just traffic lighting all of these things, but we were clarifying with our providers, what do these qualifiers mean? What do these codes mean? What does this 277CA code mean? Why do I have to send this facility information when it's the same as this over here? And what is taxonomy for? And which one do I pick? I mean, we handled all that stuff, and we took a lot of the load off of payers for helping to answer and clarify those questions. We also took a lot of load talking with the payers to understand why they want, what are you using taxonomy for? What are you doing this for? So that we could advise our providers accurately there. So one key thing is that this was a version change. Now, all those connections we've done everything from bulletin board connections, screen scrapes, all types of things to get to where we are to exchange, more the more up-to-date stuff with SFTP and other secure connections and making sure it's secure. But what strikes me is that we have that network in place and we know how to navigate it. And what's really different, and also that we're transactional. Most of what we do is transactional. We might handle the same transaction 50 times with little tiny changes between it. You don't really know which one's the right one, and you have to really shift that thought when you move into FHIR APIs, because that's more of a dialogue, and it's a lot less transactional. And also that network's not at scale yet so when we're looking at, oh, we really want to get in and help our providers with prior authorization, it's a huge burden. We want to be part of that. And we are all saying that we want to be part of that. We're excited about it. We want to do it. We look around and we go, well, okay, so who's doing it? Who can we work with? And there's crickets. We can't connect with the organizations who have something. And when you're in the clearinghouse space, you have to be able to provide an ROI. Where does your organization want to spend your money? Do you want to spend your money on something where you grow it, you spend your time on it, you have opportunity cost loss, and then you build this thing, and you are a national organization and you can only connect to 2 regional payers to exchange data? You can't prove scalability, you can't prove growth. And some of your biggest partners have portal solutions. They're not interested in API. It's just a big challenge. I probably was all over the place on that, but I'll stop there.
No, that was really good. Good conversation. So I do want to double click on a couple of things because there's been some common themes that we've been talking through here, but let's double click on a couple of things, and I'm going to give you my perspective, not to bias you, just to throw things out there. Is as it relates to the value add that payers and providers bring, right? We all know that it's it's payer agnostic, provider agnostic, EHR agnostic, and you're bringing information in. And we also know that we live in a hybrid world. I love Fire. I also love X12 and V2 and V3. So I'm multi-lover of interoperability. It sounded very bizarre. Let's scratch that from the record. But as far as intermediaries, given the fact that they are in an ideal place to aggregate that information or at least combine it, right, or make it available. You mentioned the Rails, Beth, right? It's a version update or whatever. Fire is going to go through updates until we all retire. But the Rails will probably remain the same. So as it relates to providers and payers, how do intermediaries, first of all, protect investment, right? Because from a payer perspective, you're investing in large claims platforms and authorization platforms and other things that are typically more expensive and difficult to make flexible because they're designed to run at high scale and do certain things very, very well. So having that buffer or that front door that does some of that buffering for us, it makes sense. And also the ability for intermediaries to support not just classic transaction sets, but as you mentioned, that's just a second ago, payer to payer and that type of thing, being able to serve the plethora of different transaction types and HL7 and X12 and that type of thing. So let's double click on that. So for people that are looking to understand the true benefit, let's go there. So Brian, you're right on my screen. Give me your thoughts.
Perfect. No, and I think we have to keep that in mind, right? Because it's our business model, right? And it's the folks that we work with and the ones we try to bring value at the end of the day. So I think from a payer perspective, I think what we try to keep in mind based on the technologies and the services we provide is can we offer a cost efficiency, to an existing model that's already been developed, or add a component that in line that the payer doesn't necessarily have to build themselves, right? I think it's been talked about earlier, economies of scale, improved and quality risk programs. How do we benefit and bring our service to that, improve patient outcomes, right? Always got to think of the patient at the end of the day. And then obviously the financial incentive. We have to wear both the technology that we bring to the table, but how does that affect downstream and other departments that are looking at what we're trying to bring on a component to their already existing platform that, again, cost efficiency, but where's the additional financial incentives that could be gained long term? I think we have to go in from a short-term, midterm, long-term type of a benefit, at least on the payer side. And then, obviously from the provider side, I'll go back and obviously we're talking about member retention, right? We always got to remember, how do we build that customer service within what we do that they can go ahead and pass on down to their members. So again, customer retention. But from the provider side, I think it's fairly simple. Improve patient outcomes and hopefully faster prior authorization of API. If you look at that, the API can reduce the decision times. And beat the standard out there today. I think that's at the end of the day, the consumer wins. So I'll just leave it at that for right now.
Yeah, let me challenge a little bit. Challenge is not the right word. Brian, what can intermediaries do better going forward in this brave new world?
Well, I think listen. I think that's a valid point. I think we have to listen. I think we have to understand the market. I think we have to figure out where technology and policy somewhat connect. I think what we have to listen to is not necessarily we have a service and a technology. Is that a service and a technology that the payers and providers, and I'll use them as an example, need or envision them needing somewhere down the line. So I think it goes hand in hand with communication, understanding the marketplace, and understanding client needs.
Makes sense. Dr. Rucker, what are intermediaries doing well and what can they do better?
I think the big, so I think some of the stuff, obviously the claim stuff has been honed to, I think, a pretty high degree of perfection. I mean, it just has. I think the real game is going to change to how do you manage clinical knowledge? I think the political and economic pressures have escaped the world of claims. They've overwhelmed it, maybe. And so you're going to have to think about two things. One, you're going to have to think about the whole movement of clinical data, the getting, movement, ingestion of it. The other is you're going to have to think about the analytics around it. And so it's not just the API, but your intermediary, or if you build it in-house, you're going to have a platform for a variety of modern compute, all on the same platform to maintain your sanity. And I think for anybody looking at that, probably the simplest way to get a flavor of what a modern platform looks like is to go to any of the major cloud vendors and see all of the different types of software that they support, right? Relational database, hierarchical databases, notification engines. They're all supporting multiple tools in one environment. And that's what modern computing is. So any intermediary solution has to be thought of in how is this advancing me in that? And at what point is it advancing me? Is it advancing me at the door, or is it advancing me inside the room when I'm doing stuff?
That's a great point. And you mentioned it earlier, the fact that the sense of modern compute, other industries take advantage of that all the time. We tend to lag behind a little bit in the healthcare space. Nancy.
Yeah, I would just add the word be flexible, continue to be flexible, or if you're not flexible. So I think just building off what Dr. Rucker just said, there's a lot of tools. We need analytics, we need data aggregation, we need, data transfer. There's so many different pieces and parts, and FHIR is going to play a bigger role in all of that. So I think if intermediaries, good point, Brian, that you need to listen, but I think coming to the table and listening to what the payers or the providers, whoever your customer is, can already do, what they're struggling with doing, and being flexible with a solution that meets their needs and where you can help them fill those gaps and accelerate. A word I wanted to use earlier and I didn't, but intermediaries really can be an accelerator into all this new technology.
Yeah.
And so I think being flexible with your solution, don't try to come with a cookie cutter solution that we've got to fit into, but listen to what we need and bring us the tools that you have that can meet that, and then act as an accelerator to help us all get to, a common spot. If I look at the continuum, we've got to have some milestones that say, somebody put it in a comment, that we're all going to make it to here, and and 0057 is a good beginning to help us get there, right? But then what's next, and be that accelerator to help keep all the other players in an even road journey, or at least relatively even, so that we can continue to work together and do new and exciting things.
Yeah. Right. Great point, Nancy. Great points. Yeah.
Yeah, I think bringing together the acceleration, Nancy, you hit the nail on the head, the modern compute. And so, Bob, I know you're going to hit us with some thoughts here.
Yeah, well, I think and Nancy, as I'm finding under her mentorship, I align my thoughts quite a bit. But I think there's a real opportunity for intermediaries to think differently about their business, be able to segment that to fit the need in the moment for the customer that they're dealing with, right? Because a big challenge, intermediary is also, you can preface it with this, and it becomes a big challenge for a lot of payers, right? We don't want to lose our relationship with our providers in the exchange by virtue of giving that up to an intermediary. So I think that staying ahead of where the market is going and identifying how we can think differently about this exchange or bring new value to the equation I think is a real opportunity for intermediaries in the coming year.
Yeah.
I'd like to add one more thing, Patrick, if you don't mind. It's important to say that when you're immediate intermediary, by default, you're in the middle. Okay, so you have to have somebody, you have to have providers who want this service, and then you have to have a payer who offers that service in order to be that go-between. We can't manufacture it. And one of the things that we're finding is that we're not seeing a whole lot of demand from our providers for a prior authorization. We know that there's a need for it, but we're not seeing a whole lot of demand, which as we investigate those types of things, we find that they're getting their solutions other ways through payer portals, and primarily payer portals. And other processes, and they're really just not, that's artificially reducing the demand for interoperable solutions, because they're somewhat satisfied with their prior authorization. Only 3 of their 30 payers offers electronic prior authorization, and so they don't really mind doing those on the portal. And so we're not seeing a lot of drive. So it makes it very hard for us to connect these two, because the people that you find who are interested in scaling up prior authorization, we may only be able to scare up one of their payers who would do a Fire API, and it's not even ready yet, and they don't know when it's going to be ready. So we do have some dependencies on either side. So it doesn't, in some sense, we really, it makes it hard for us to hit the ground running and really kind of churn something out. Now, we are engaging more and more and more with this, with the fire groups, and Cooperative Exchange in particular has a huge initiative to try and start getting that knowledge and start to grow that organically. But it feels like it's going to be slow. So I kind of equate that back to, you remember years ago when ATMs first started. When the ATM, you're all excited because you got this card and you can go to your bank, inside the bank, and use your ATM card just for your bank. And then a few years later, they started putting them outside or in different places. But you could still only use your bank. And then a few years later, now you could get this special network, and you could use the ATM for just those networks. And then it became all kinds of banks. It was pretty much seamless. And then you got your Cash Apps and your Venmos and all this stuff, and it just got more sophisticated. And that did not happen overnight. Those things had to grow based on demand, based on visionaries, based on all kinds of things that drive that too. And it took a long time, even though people wanted those things. And sometimes people didn't even know they wanted it. And then they got the convenience of it and loved it. So I think we should also kind of back up and say that sometimes this stuff has to grow organically. It may be a little bit slower. We can accelerate it, but only so far. And then you hit some tipping point and things really start moving quickly. So just some thoughts.
No, those are good thoughts. And I like your term artificial, but I would also maybe challenge it a little bit to say, shouldn't intermediaries be pushing the innovation or facilitating the innovation to smooth some of these processes out, like prior authorization?
Well, we do that, but remember, we don't have access to the patient population. We act on behalf of the patients, but patients and providers who want this have to drive that. And if they're getting those needs met another way, we can't manufacture that desire.
No, not manufacture, but over time, to your point, provide capabilities so that they get better over time. Yeah.
Yeah, but it's a mixed bag, because you really work to drive that, but if you can't allocate millions of development dollars for something that you cannot project a growth on. I can't show that, oh, in 2 years, we should be able to send this many transactions or this many prioritization requests or this many, satisfy this many things over X amount of time. I can't show that to our shareholders and say, yes, this is worth 3 million because we're going to be in the clear after 5 years. You can't do that. There's no chart. Now, standards help, mandates help, things that say payers, you have to offer this, or so-and-so, you have to do it this way. Those things can help drive that. And we certainly will push that. We want it. We are excited about it. But we're operating within some constraints that don't let us go as fast as we would like to.
Patrick,
Sherry,
can I
yeah,
just,
Yeah.
no, I would just like to add to that. I think one of our values when we talk about the values is that we're really interested in being able to identify collaborative opportunities to be able to further advance. So those that are ready, we're looking, how can we be able to meet those needs? And I think today was very enlightening to me. I think the common thread we heard is that there need to be an alignment of incentives across stakeholders to get engaged. And I think we really understand the diversity of approaches, the different business needs. And going back to, I think, Dawn and Bob and Nancy's comments too, is that we need to listen. It's a real opportunity as we look at being able to be innovators to look at, what are the different business needs? It's as we say, we have the infrastructure, but we also have a learning together to be able to understand the different applications. So you have the clinical, how's that going to fit in within those workflows? And again, going back to Nancy's comment, we're able to provide those flexible solutions on technology, business, as well as the overall operational effects. So it's learning. And then as we begin to identify those, how we can build off those business use cases, just like we do in FHIR, the API use case, that let's start together. So we're really interested, in more transparency. Who is doing it? How can we come together? And each of us, to me, from our conversations today, all have a piece of something. We all have a piece. You have the patient API, some of you have the provider, and everyone has a piece of something. And we have the infrastructure and the knowledge, but it's bringing together. So one of the needs that I think we as intermediaries, when we look at what we can, achieve better together, is the ability to be able to communicate quicker, expedite our information sharing, so that we can begin to, right now, it takes months to hear someone implemented this and the mistake or the challenges that they did, where instead of us each, and what I refer to as a silo implementation effort, is each of us are making our own same mistakes where we could have, learned more from each other, but begin to look at where are the APIs, where's something we have consensus as a starting point, and then being able to work together collaboratively to connect all these pieces, and we definitely have each of us bring something to the table. So the more that we can increase that community in working together, we have a real interest to support it, because this is the future today. And so it's very exciting. I think we all are there. We really appreciate it. But, let's work together to be able to really get this into a functional across everyone where it brings value, and be able to identify those priorities.
Sure, with collaboration, to your point, being an absolute pillar of that. So with that being said, I know we're about at time. So what I'd like to do is let's go through the list. If there's any final thoughts, let's just keep it. We've covered a lot here today. So this has been a great conversation. I appreciate everybody drinking a lot of coffee before this. So this has been good. So let's go through quick, just a couple of, what you want to leave the participants with, our audience with today as it relates to intermediaries, just a couple of words. I'll start with you, Dr. Rucker.
Computable interoperability. So not just the API, but what's behind it.
Beautiful, beautiful. Nancy.
Make it easy. If people that are struggling to get started, the best thing an intermediary could do would be to come to me with a solution that makes it the easiest for me to implement and helps me, to the point that Sherry was making a minute ago. There are maybe it was Beth, I don't know. But anyway, there are very strong KPIs or values for especially prior auth for both the provider and the payer. So help us get that organized and documented and socialized so that, because along with easy, showing people all the value, this can go fast.
Yes, acceleration.
I'd say lift your horizon on your vision, right? That we need to we're struggling with how to get to 2027. You can be a partner by helping us get beyond that.
Yep. Sherry.
I think when we talk about priority, and Nancy, going back to you on maybe a starting point is the prioritization. We have a CMS regulation, the prior auth final rule. We actually have an implementation guide hybrid that supports also the X12. And we have collaboration with DaVinci and HL7 and X12 on the crosswalk. So a lot of that infrastructure is there to make that connectivity. And I think that may be, part of the dialogue of a community is how we can start maybe doing that and be able to bring that to more reality.
Beth.
I would say that it's continue to stay engaged in these multi-stakeholder groups. It's conversations like this and being part and stepping out of your comfort zone, being part of the different expert groups and talking and listening. I think that goes a long way because then you can glean the business cases, you can glean the things that you need, and you make the contacts to actually make things happen. So I think staying engaged very closely and working toward actual concrete pilot efforts where we can show that it actually works is where we want to be.
Yes. And Brian.
Well, I'm just tickled to be the square next to Don. So I think that's, that's my highlight for my day. But I think, the big takeaways for me is engage and communicate across all cross-sectional aspects of the organizations that we work with. And through that, develop strong KPIs that drive value and show definitive ROI.
Perfect. Well, thank you all very much. This has been a fantastic panel, and thank you to all of our participants today. Michael, I'll turn it back over to you.
Patrick, thank you so much. And not only this panel, but all our panels today have been absolutely all-stars. Thank you so much for being a part of this WEDI event. Charles, are you online? Would you like to say some closing words to the audience?
I am, Michael.
All right.
Sorry, sun in my eyes, which is nice, and as cold as it is here, to have sun coming through your windows. So, wow, what a great event. Thank you all for sticking with us. Thank you for all the panelists who had, in many cases, double duty or triple duty. It was great, and yeah, for everyone who hopefully found this as interesting and as I did, and I just love talking about 0057, thinking, of course, about how we can turn that into something like 007. But anyhow, have a great rest of the afternoon. Thank you for joining us, and we look forward to your participation at future events. And thank you again to One Up Health for their support of this conference. Great, thank you again. And Michael, thank you for making sure that everything ran so smoothly.
Not a problem, my pleasure. And for everyone on screen, you can see that this is actually one of 5 in our CMS 0057 implementation update series. So coming in March, the payer implementation update. So be sure to visit wedi.org and click on events for more information on our upcoming events.
Take care.
Thank you.
Bye.